Everyone from your team here?
I do.
Right, great. Good afternoon, Mr. Miller. How are you?
I'm good, thanks.
Okay. Mr. Adcock, I'll call the meeting back to session here in a moment, and then I'll have our counsel swear you and your witnesses in, and then after that, we will just turn it to you for your presentation.
Thank you.
All right. Mr. Miller, we can go on the record.
Okay, we're on.
All right. We are resuming our hearing of August 13th from this morning. And next we have the Springfield Hospital budget presentation. I'll ask our counsel to swear in the witnesses, and then we'll turn it to Mr. Adcock and his team for their presentation.
Afternoon, folks from Springfield Hospital. What I'm going to do is administer the oath. What I'll ask you to do is, after I do that, unmute yourselves and then individually state your name and then affirm the oath. And if we can just go through each person, that way we have each witness testifying for Springfield clearly on the record. So with that in mind, I'll just go ahead and administer the oath. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
I do.
This is Robert Adcock. I do.
John Bond, I do.
Kata Westcott, I do.
Okay, witnesses are sworn in. I'll go ahead and turn it over to Springfield for its presentation.
Perfect. Chair Foster, are we going to share the slides, or will you do it on your side?
If you have them available, you can go ahead and share. And if not, let me know and we can figure it out on our end.
Okay, Kata, can you accommodate that, please?
I am working on it. Oops, that's not the.
I see some from last year, I think.
Yeah, we don't want to do.
Yeah,
we don't
I'm
want
not
to
sure.
do last year's again.
And I don't even know where that's coming from, which is weird. So
And we're moving forward, not backwards.
we would like to move forward. Yes. This is looking a little bit different than what I'm used to. So bear with me here. There's always technical difficulties.
Well, if you give us last year's budget, we'll save some healthcare dollars.
All right, let me try this again. It's still last year. What the heck?
Maybe the date just wasn't changed?
No, this is definitely a different presentation, and I have it on my screen. Here, what about now?
Okay, we have them now.
Okay,
That's
good.
great.
Perfect. With your permission, Chair Foster, I'll go ahead and proceed.
Please do. Thank you.
Thank you. First off, I want to thank you for allowing us to have some time to talk about our hospital and our upcoming budget for fiscal year 26. On the cover of our budget presentation this year, our theme is keeping healthcare local. We think that supports all of the goals that Vermont has now around affordability, access, and sustainability for our state. And so on the cover, we have Dr. Kilcheski, who is one of our urologists here, and he's the primary provider of men's health services for our program. So we started off with Dr. Kilcheski this year. And I want to, before I get into the presentation, I have quite a few thanks to give out to many people. First off, I want to thank the Green Mountain Care Board and AHS and all the other partners that we have in the state that are working on healthcare reformation in the state. You know, we know that we have to do better for Vermonters. We know that we have to have sustainable hospitals, affordable hospitals, and access for our fellow Vermonters here in the state. So, you know, we applaud the work that's being done towards that, and want to start off our presentation by letting you know that we're committed to being an active partner in joining that process and contributing to that process. Also want to thank my Springfield community in our primary service area. You know, we've been through a number of years of challenging circumstances here at Springfield in our community, and our patients have stuck with us through this time and continued to have faith and confidence in the care that we provide here. I certainly want to thank our hospital family. We have a lot of people who have dedicated their lives to the hospital at Springfield and taking care of our patients, many of whom are their neighbors and relatives. And, you know, I would be remiss if I didn't thank the people that have given this time to the hospital and have also stuck with us during these difficult times. So many thanks to our Springfield family for the work that they do every day, you know, to take care of our community patients. And, you know, we work in a hard environment in healthcare. There's a lot of easier work that people could do. And we have a lot of people who have dedicated their lives. We have quite a few people who are in the multiple decades of service here. And, you know, we celebrate them and thank everybody on our team for sticking with us through this. First slide, please. So what's our goal for 26? At Springfield, we're completely on board with healthcare transformation. Our budget, we want to position our hospital to meaningfully contribute to healthcare transformation. And to do that, we want to make sure that we preserve access and preserve our assets as we go through the transformation process. I mean, we're working very hard not to limit access or reduce or diminish any of the services that we have here at the hospital. Many of those services that, you know, the last couple of years we've been working to grow and bring patients back from other hospitals back to Springfield. We're also working on a number of what we call our operational pathways, things like improving our quality, or reinvesting in our infrastructure and assets, recruiting providers, reducing travelers from our hospital staff, and continuing our strategy as a high quality and low cost provider. Next slide, please. I want to just remind everybody, particularly for the benefit of our new board member, nice to meet you for the first time electronically. But I want to call to everyone's attention the history that we've been on here. So as you recall, beginning in 2019, Springfield Hospital was in Chapter 11. You know, and as we worked through our financial restructuring at that time, a lot of really large restructuring efforts were undertaken. In some respects, I think that we were early in transforming our hospital because we made a lot of tough decisions were made here before I got here, such as eliminating our obstetric service. We had a large reduction in force, and you can see as we go through the presentation, you'll see that we've continued, although our expenses have grown over the last 5 or 6 years, a lot of the savings we did continue to be baked into our pie going forward. So things like our reduction in force. At one time, we had a shared chief medical officer, which we no longer have. We've reached our professional development department was restructured, and since we emerged from Chapter 11, we've subsequently closed cardiology and moved oncology from an on-site program to a infusion and telemedicine program. So all these savings that we've already done over the last few years are inherently baked into our numbers as we go forward. Next slide, please. I'll let Kata explain our history of cost increases in NPR growth.
I have to unmute first. Yep.
Okay, there you are.
This is expanding on what Bob was just referring to with our history, our cost reductions, our Chapter 11. This is a slide showing our budget history since fiscal year 19. Fiscal year 19 was the year that we went into Chapter 11, shown as at 0% on this graph. For the 5 years after fiscal year 19, from fiscal year 19 to fiscal year 24, our budget levels for both NPR, net patient revenue, and expense were below the levels that they were in fiscal year 19. And you can see that those levels and these percentages are shown as a comparison to what they were in 19, or decreases in each of these years of 15%, 15%, 9%, 2% below fiscal year 19 levels. And they did not reach fiscal year 19 levels until fiscal year 24. And that's what that big red X on the screen represents. So a lot of our cost reductions we've been making, since fiscal year 19, and we're already a very lean organization. Fast forward to fiscal year 16 with this year's budget, which is on this graph. Our fiscal year 16, both NPR and expense levels represent a 16% growth over fiscal year 19. So over that 7-year period, our budget this year, if you take the 16% growth over that 7 years, it's an average of 2.3% growth per year on average for NPR and expenses. That makes it challenging. Our history of making those cost reductions in the earlier years makes it challenging for us with the budget to budget growth targets when they're looked at from year to year, because it doesn't take into consideration our history of making some of those cost reductions earlier on. So we hope that the board will take that into consideration when evaluating our budget this year.
And Kata, I think it also merits bringing up on this slide that over the last few years in FY17 and in FY20 on the NPR side, we budgeted a 0% growth in those 2 years. So we had zero commercial rate increases in those years. So I think it's important that we also note that during that time, we've had a couple of years where we had no increases. Next slide, please. So yes, we agree with the direction that the state is going in terms of healthcare transformation. We want to be part of that, and we share the goals that everyone has at the state leadership level to improve access and quality, control cost, improve affordability. Something we work a lot on here is our hospital sustainability. Obviously that's been kind of our job one emerging from Chapter 11, is to move the hospital where it's sustainable financially, and then participating in the ongoing transformation work that's being done in the state. Next slide. One of the important pathways that we're working on, and we have a number of pathways that our team is working on to improve the daily performance of the hospital, is our quality pathway. And on this slide, we're showing how we're doing on CMS national quality indicators. And you can see that we are not statistically different on these key clinical performance measures. So we're no different than the national rates based on the CMS's determination of what is statistically significant. Next slide, please. We're also using our patient satisfaction data as an indication of quality, and you can see our progression over the last couple of years that we've had with our patient satisfaction. And starting in 25, we have included our physician practices and our outpatient services in this, which has given us a big bump. So one of our key service areas, of course, is serving the outpatient needs here in Springfield, and you can see our patient satisfaction has done well there. Next slide. Also want to stop and point out and congratulate our physician practices. If, as you recall, in Springfield, when we separated from the FQHC took ownership of the primary care base in the marketplace, and we took ownership of the specialty practices. And the ones we have are summarized on this slide, and you can see we're doing very well on our patient satisfaction on all of the practices. I will point out here that we did have some low scores in general surgery, and that was primarily around the fact that we lost our full-time general surgeon last year in the fall. And we'll talk about our successful recruiting efforts to replace that doctor as we go forward. But physician practices are doing very well, and by and large, the wait times and the care we're providing are, doing very well in terms of our patient ratings. Next slide, please. This slide shows our HCAP scores compared to NRC averages, and we're certainly looking to improve these. One of the things we've done with this on our inpatient unit is we have changed our inpatient physician group, and starting in May, we have a new group that is providing that care now. So we're putting a big effort here in improving those scores. The main action we have taken is to bring in a new physician group to do that. Next slide, please. I want to talk a little bit about our current year, FY25. So we have been successful in reducing a significant amount of expenses in this current fiscal year. And some of those expense reductions have been offset by other things that we have had challenges controlling, and we'll cover those when we go through those slides. But we have not made any changes to our corporate structure or any material changes to close or reduce any service lines in this year. We have restructured a few things, but we haven't closed anything or restricted access to anything this year. We continue to invest in our quality, revenue cycle, and technology, which are all those pathways that I spoke about earlier, the things we're moving through these strategies to improve the quality of our hospital in a number of operational areas. Again, we replaced our inpatient hospitalist team in May, and we will welcome a new emergency department permanent group in September. Since May, we have been using locums to cover our emergency department with a considerable amount of work on behalf of the leadership team to manage that. But we do have a new group that is starting in September, and we're looking forward to that. Next slide, please.
But before moving on to the next slide, I do want to add on the point of investing in revenue cycle. We know that our AR days are on the high side. We're making improvements to work on addressing that. We're working on improvements on workflow, patient access. We have new leadership in patient access just recently, working on prior authorizations. Really, revenue cycle is a priority for us right now. There's always opportunities, but that's something that we're zeroing in on, knowing that our AR days are high, and we need to address that. So I will take the next couple of slides, I believe. The current year projection for fiscal year 25 this year, this slide is on revenue. We are expecting our gross patient revenue to be over budget. That's what we've experienced so far this year, and we anticipate that to be the case at year end. We've seen an increase in our inpatient census, both on the med-surg side and swing. Also an increase in outpatient utilization in many areas. We also have, as Bob alluded to, with our emergency department provider change in May, we have a permanent group coming in September. But as of May, when we have new locum providers on, we changed our professional billing so that the hospital is now taking on that billing. Previous to that, the former provider group was doing the billing. It's not new revenue per se to the system, but it is for the hospital. So we'll have new revenue on our books, but we'll also have increased provider cost as an offset to that. And it's projected to be a little bit of a savings for us to take on that billing. One of the main goals of the hospital taking on the professional billing for the ED is that our patients were confused. There was a lot of dissatisfaction and patient complaints on receiving multiple bills when they were seen in the ED, one from the hospital, one from the ED provider group, another one from the radiologist. So by consolidating or having that professional billing done by the hospital, patients will be receiving less bills and hopefully will result in less confusion on their end. Charity care and bad debt. We've seen a significant increase in charity care this year. We'll cover that in a couple of slides from now. That between charity care and bad debt is projected to be about 2.3% over what we had anticipated. Some of the drivers for that is for charity care, our certified assister. We have had, he's been on board for about a year and a half now. He just recently, in the last couple of months, moved his office from off campus or down the hill from the hospital. He's now on the main campus in the center of the hospital and is very busy seeing patients throughout the day. We've also seen an impact from Act 119 that went into effect at the end of last year. And our bad debt still continues to be on the high side as a result of high deductibles and copays and patients that are unable to afford health insurance. Our net patient revenue, with the gross patient revenue being ahead of what we think is going to be for the end of the year, as well as charity care and as well as an increase in charity care and bad debt, we still believe that our net patient revenue will be on or maybe above budget. Of course, that's contingent on utilization for the rest of the summer, as well as charity care and bad debt. Potential grant income, it's an ongoing process for us to apply for grants. We could potentially have some grant income recognized between now and the end of the year. And one bullet that we did not have at the time of this presentation and submitting it last week, but what has come about in the last couple of days, on Monday, August 11th, we received our employee retention credit check from the IRS. That was $5.6 million that we received on Monday. We did not have that in our budget this year or our projections this year, as we had filed for that credit back in January of 2024, a year and a half ago. And the timing, we were uncertain of the timing of that. We were uncertain of our eligibility in terms of the IRS feeling the IRS's eyes and whether we were eligible. So we were really uncertain about that, but we were happy to receive that check on Monday, and that was a huge help for the hospital. So we will be recording that as other operating revenue in fiscal year 25. And that, again, it was not budgeted this year. Moving on to the next slide, our current year projection this year for expenses. Our expenses are expected to come in significantly over budget. We have main drivers causing that. Travelers is a big one, liability insurance, pharmacy drugs, our ED provider locum expense. So as of May 1st, with having locums from May 1st to September, the mid-September, before we get our permanent group, those expenses are much more expensive than what they would be. We added a general surgeon to meet community need. We also added security in our emergency department to address workplace violence. And in June, we implemented a nursing wage adjustment for our nurses. We have a strategy to reduce our traveler expense, because that expense for us has been significant, since COVID. One of our strategies to reduce that is to increase our nursing wages, which we did as of June, and we're already starting to see a shift in being able to recruit and retain some of our nurses and to convert travelers into our own employed staff. The note at the bottom, please recall that for our current year 25 budget, our original budget was reduced for both NPR and expenses by $4.2 million, which was a 6% impact. The expenses were lowered to $64.4 million for our 25 budget, allowing for 0% growth over our 24 actual expenses. Our 24 actual expenses were also $64.4 million, almost exact. So we had 0% growth and very little flexibility in this year's budget for expenses. And that is making it a challenge for us to meet our 26 guidance on expense growth. This is a slide on our payer mix trend since fiscal year 23 to current. We've seen a little bit of an increase in commercial payers. Like everybody else, we're seeing a decrease in traditional Medicare and an increase in Medicare Advantage. We're seeing a slight increase in private pay. We do have a high Medicaid population. Combining our Medicaid population is between 19 and 20%, which makes it a barrier for us when Medicaid is underfunded. We do have a 3.4% private pay population. And I do want to add that these percentages for payer mix are based on gross patient revenue.
We wanted to give a little update on our case mix index over the last couple of years. Right now, during that period, we've seen some fluctuations depending on seasonality and what was going on in our marketplace. During this time, our average is somewhere around 1.3, which is a little bit below average for similar hospitals in America. But even the higher CMI months indicate the work we're doing, providing more resource intensive patient care. It fluctuates through the year, but in our marketplace, our social determinants of health tell us that our population is a couple of points older, sicker, and poorer than the state average. And that is reflected quite a bit. So even though the CMI might not be as high as some other hospitals, we do see a lot of challenges around patient placement, discharge planning, and other social aspects of the patients that we see here. Lots of mental health patients coming through our emergency department, some of which can go to our inpatient mental health facility in Bellows Falls, but a lot of discharge planning concerns around all of those. Next slide, please. Kate, I'll go back to you.
Yep, thank you, Bob. This is our operating budget for fiscal year 26. Our operating margin is basically at break even. Doesn't provide us a lot of flexibility to improve our reserves, reinvest in capital. This is the best that we could do with the guidance, and is going to be difficult for us to improve our sustainability with this kind of a margin. Anything you want to add to this, Bob?
No, I'll just say that the margins at this level pose a challenge to us in terms of our continued reinvestment and recapitalization of the hospital, particularly for us starting back prior to us being in Chapter 11, as the hospital was experiencing challenging years prior to that time, there was a challenge investing in capital and replacing, making repairs to the building and replacing medical technology. And we've had a pretty good campaign of addressing many of those things over the last 3 or 4 years, much of which has been funded by grant income.
So our benchmark comparisons for the 26 guidance, this is a slide on our comparison for net patient revenue growth. Our net patient revenue growth budget to budget is a $5.3 million increase, which is 8.3%. That growth this year is a combination of the ED professional billing change, which we talked about, utilization increases experienced in 25 compared to the 25 budget. A lot of those increases in 25 are baked into our 26 budget, as well as we also have some anticipated growth in the OR and endoscopy for 26 related to adding a second general surgeon to our team. Also in the budget to budget growth for net patient revenue is a 3% charge master increase, as well as a 3% commercial reimbursement rate increase. That is the components of the 8.3% budget to budget growth. Of that growth, the billing change that we talked about represents $2.3 million or 3.6%. We are requesting for that to be carved out of the budget to budget growth since it was not in our base in 25. Again, this is not new money. This was previously billed to our patients by the old provider group. And this was billed out of state. And now that brings that revenue back in state. With that adjustment, it brings our net patient revenue budget to budget growth to $3 million, which is a 4.7% growth over the 25 budget. That's 1.2% over guidance, and that's equivalent to $775,000. Our benchmark comparisons in terms of operating expenses, we have budget to budget growth of 6.1 million, which is 9.6%. Please keep in mind that with the budget to budget growth, what we had discussed earlier, that our 25 budget for expenses and NPR was reduced by $4 million, essentially experiencing 0% growth from the 24 actual expenses, making it difficult for us to meet that benchmark this year. Also, please keep in mind the graph that we went over with the red X of our history since Chapter 11 and fiscal year 19, when our average over the last 7 years, including the 26 budget, was only a 16% growth in expenses, which equates to about 2.3% per year. So that's considerations to keep in mind with the 6.1 million budget to budget growth for expenses, but we have some carve outs from that we would like to be considered. One is the impact of the ED billing change, and as a part of that change, the cost to the providers will go up, but that will be offset with the revenue that we receive. So the cost of that, which was not in our base in 25, is $1.6 million or 2.5%. We also have some expense exceptions in addition to that of $2.6 million that we feel should be considered as not included in the growth calculation, and that is about 4.1%. And with those carve outs, we come up with an adjusted budget to budget growth of 1.9 million or 3%. This is a breakdown of the 2.6 million, which doesn't include the ED provider cost increase. We feel that most of these expenses are unavoidable and just reasonable expenses that the hospital has had to incur. Anything you want to add on this slide, Bob?
Also, we had quite a challenge around expenses, particularly, our increase in volume and inflation on pharmacy costs was quite high. We had unexpected increases in our employee health benefits and our professional liability insurance. We talked a little bit earlier about our emergency department volume and the mental health patients we have there. So it was imperative that we increase our security. And then we did a market adjustment for our nurses so we would be more competitive as part of our overall strategy to reduce travelers in the hospital.
Our 26 patient care revenue, a lot of this we've already covered in the previous slides. One of the main impacts or differences is the impact of the new emergency department professional billing being taken on by the hospital. We feel that this should be excluded from the budget to budget NPR growth calculation. Again, the impact of that is 2.3 million or 3.6%. Again, this is not new money. This is previously billed by our former out-of-state provider. Our revenue growth includes the 3% commercial reimbursement rate growth, a 3% charge master increase, and new utilization anticipated next year for OR cases, endoscopy, related to adding the second surgeon this spring, and other utilization growth that we have baked into the 26 budget related to growth that we've already been seeing in 25. This slide is our bad debt and free care trends over the last 5 to 6 years. The yellow represents free care, and these are percentages as a percentage of gross patient revenue. The orange is representative of bad debt, and the blue is the total of the free care and bad debt combined. You can see in the 25 projected number compared to 24, we've seen a significant increase in our charity care. Again, that's related to the work that our certified assister is doing, Act 119. We are seeing our bad debt to free care ratio decreasing. In previous years, that ratio was north of 3. Now that's about 1.5. So we've seen that ratio come down. Again, still seeing higher levels than what we would like of bad debt, high copays and deductibles, patients that can't afford health insurance. We are anticipating to see, or hoping to see, a decrease in bad debt next year as we are changing our early out vendor, or our vendor that we use to collect on self-pay. We're changing that vendor out. We're in the process of doing that as we feel that we'll have better performance with the new vendor on collections. Okay.
All right, just to summarize, if you look at our budget in terms of volume and utilization, in 25 we've seen increases in a number of areas, including outpatient volume. We believe the volume increases are a result of a couple of things. One, it's our continued reinvestment in the hospital and continuing to re-win the confidence of our local market area and bring back patients that came to the hospital 10 years ago but have lost confidence in us throughout our financial difficulties. So we think those strategies to redirect patients back to the hospital we believe they're working. They're just, particularly when people understand the reinvestments in the improvements that we're making in the hospital to better serve our community. So on utilization, we are projecting outpatient to continue to increase. We have seen increases in med-surg, swing, and observation, and certainly swing and observation are very appropriate in lower cost services. So we expect those to continue. General surgery was slow at the beginning of FY25 due to the loss of our surgeon. Now we have 2 full-time surgeons. We have the new one that was recruited, and one of our part-time doctors came up to full-time. So we now have a full complement of general surgeons here to serve our community, and we anticipate that resulting in OR cases and increased endoscopy cases. Those doctors, by the way, we do not have a gastroenterologist here, so those doctors are doing the endoscopy work here as well. In mental health, we've budgeted that flat over FY25 projected. We continue to review our referral and admission process for our mental health program. In 25, our utilization was limited because of the lack of on-site medical support. The unit is 15 miles from our main hospital located in Bellows Falls. We also do not have security, and transportation challenges are consistent with us moving patients back and forth. And we've also had some days where we had bed availability challenges when building repairs were taking place. So we budgeted the inpatient mental health flat this year. Next slide, please. I think the next couple of slides, the important thing is to look at the green, and the green represents the steady growth that we've continued to see over the last couple of years. We believe our strategy is working. It is working slowly, but we are regaining the confidence of our community, and some of the volume we had previously is returning. And you can see here the light green shows the change between the FY25 budget and the FY25 projected. And then the darker green shows the change between the budget to budget from FY25 budget to FY26 budget. So the green boxes show the steady growth and show that our strategy has been working. Next slide. So that's the inpatient side. This shows our other ancillary volume, surgery, and the progress that we're also making in our hospital physician practices. And you can see lots of light green and dark green there too. Some important ones to note are things like the growth we're expecting in gynecology and women's health. I think that's pretty important. We have done a little work around our ENT, and we have one of the only ENT surgeons in the area. He is quite busy, as well as our increases in general surgery that we're anticipating. Next slide. So what's our big picture? Well, our expense growth overall, I mean, we've seen that over the course of the last few years, on the average, it hasn't been very large. We have had quite a few exceptional expenses this year, but we're seeking, we're working on our cost savings initiatives and always trying to improve our financial impact. We've been addressing these financial challenges since we were reorganized in Chapter 11. So we start with a smaller base, and we work very hard to squeeze every dollar we can here. Now, we have had some success with some current fiscal year cost initiatives, and we'll summarize those on the next slide. So we've saved approximately $1 million in the current fiscal year that partially offset some of the increases that we've had. Some of those are around restructuring of our orthopedic practice. So we have reduced by one orthopedic surgeon because we did not have sufficient volume for two. And with that reduction, we've also rearranged some of our call coverage because we really don't have that many orthopedic on-call cases unless it's ski season. And when it's ski season, we do have a lot of after-hours things, but in August, not so much. We have relocated our physical therapy from Ludlow, and we're now serving those patients in Bellows Falls and here at Springfield. We had a loss of a therapist there, and so that program is temporarily closed when we've redirected those patients. So hopefully we're not expecting an access issue with that or as we go forward. And again, our big challenge, one of our big cost challenges this year has been to try to reduce travelers. We have been successful in eliminating about 9 of those going forward, but we still have a lot of work to do around this. We've had 2 primary strategies around this. One is in March, we increased our differentials, shift diffs, and after hours pay to try to be more competitive on those shifts. Had some success, but not as much as we were looking for. And now we have done a market adjustment for our nurses, which is now starting to move the dial on eliminating and reducing travelers and converting those travelers to regular hospital employees. We have reduced one position in our infusion clinic by improving department flexibility and cross-training nurses from other areas. We've frozen a position in administration, which was actually the executive assistant who served the administrative team. We are now sharing a position with another department, but we have that position frozen for the moment. And we've implemented a process with our administrative team where we review all new hires, and no one can be hired without us reviewing it now. So we're sure that every employee we add, we need. And then, of course, all of our ongoing expense reductions that we try to have a sharp pencil on everything we spend that's discretionary. Next slide, please. So on our FY20, so that was 25 projected. So now with 26 budgeted going forward, you can see that we have been successful since Chapter 11 in reducing overall FTEs. In 2019, we had 337 worked FTEs compared to our budget for 26, which is 322. So we have made efforts there. We do have a cost of living increase budgeted of $433,000, which we need a small market increase every year to stay competitive. We have the wage adjustment that I discussed for our nurses that we need to help us be more competitive and reduce travelers. And that is working now. We have now reduced nine positions, and hopefully that's going to continue growing. One area of particular trouble for us this year has been increasing expenses in pharmacy. And some of that's volume related, and some of it is just overall inflation and higher prices. So we have a 22% overage for 25 projected, and we have a 12% increase budgeted. Next slide. So again, just to stay on topic, what does Springfield want to do? What is our vision for this year? Well, we want to be part of the solution, and we want to continue to keep care locally. And when you look at the care that is not local for Springfield, most of it is exiting and going out of state. And we would like to bring more of that care back to Vermont, improve access, make it easier to access care. And all the numbers we have show that the care that is appropriate for us to provide costs less. And so in 2023, we had 1,280 inpatient discharges that went to New Hampshire from 5 of our key zip codes here in Springfield. So keep that number in mind, 1,280 patients. Many of those were tertiary patients that was appropriate because we don't provide that care, but quite a few of those patients were in the DRGs that we do provide. Next slide, please. And that's the purpose of this slide. These are the top 5 DRGs that our hospital presently takes care of, and this compares our Medicare reimbursement for each of those DRGs to the other hospitals in our area. And the primary hospital in our area that we have the most out-migration to is Hospital A there, and we'll talk about Hospital A in the next slide or two, but I want you to call to your attention the difference in reimbursement between the different DRGs. And again, these are the ones that we provide. These are not ones that we do not provide. And this is CMS cost report data, and it shows about a 30% potential savings if we can bring more of these patients that we are capable of serving back to Springfield.
So Mr. Adcock, is this the reimbursements from Medicare that you're showing?
Correct.
So if you bring it back to Springfield, Medicare would save these amounts, the differences you're showing here.
Correct.
Got it. Thanks.
Next slide, please. I just wanted to show a little bit more comparative data around this narrative. 116,503 total New Hampshire discharges for this period. Hospital A, which is the Hospital A from the previous slide, had 21,588 of those. For all New Hampshire hospitals that had Vermont zip codes, 10,382 New Hampshire discharges came from Vermont zip codes. So over 10,000 patients came from Vermont and received care in New Hampshire. Hospital A had 9,168 of those, and 566 of those came from our primary Springfield zip code. And so if you think about what is out-migration costing Vermont, and we believe it's significant, and that's one of the reasons why we want to keep bringing our historic patients back, so we can have better accessibility, more affordability, and lower cost. So if you think about the impact of this over a long term, it makes sense for us to provide more care in Vermont. Next slide, please. So from a strategic standpoint, what our strategic considerations is, our big picture is we want to be part of the solution. We want to maintain access and reduce cost. When we look at our community health needs assessment, mental health continues to be a huge concern here in our marketplace. And we work in a primarily in a three-part mental health program here that we're partners with our local designated agency and our local FQ8C North Star to provide mental health in our area. We are the inpatient provider, of course, and those beds are at Bellows Falls at our center there. But we also want to explore other options for increasing mental health coverage here in terms of looking at a geriatric program, an intensive outpatient program, or a partial hospitalization program. So we want to continue to do collaborative work around what are the appropriate services and how can they improve access and improve affordability here in our service area. Of course, we constantly working on reducing potentially avoidable ED utilization. One of the things we're looking at for that is a chronic disease program where we would have a way to intervene in that patient group to try to keep them out of the emergency room. We do have an aging population. We have a very nice adult day outpatient program. We believe that program offers the potential to reduce patients who have to be moved to nursing homes because it gives the family a nice respite and it helps with the cognitive function of those patients. So we have a nice program. We are constantly looking at that and try, because we think the more people we serve there, it's a lower cost option to those people being in nursing facilities. And then again, out of the box thinking, we're flexible at looking at doing anything that makes sense in terms of supporting the healthcare reformation process here. We have other ideas to explore. We do have a list of possibilities that we talk about all the time, and do those make sense for us? Some of those possibilities are in line with some of the transformation suggestions that have been made by Oliver Wyman or by RHRC, and some of them are things that are just things that we see working in our own backyard. So next slide, please. So what is our ask today? Well, we realized that we weren't able to generate as many short-term cost savings, perhaps as some of our colleagues were. But we want you to keep in mind the history that the hospital has already had in terms of restructuring and cutting costs and maintaining those cost savings over the last few years. So we're requesting an 8.3% NPR increase. 4.7% of that is to carve out for the emergency room building. So that's not new money. That's money that was already being billed, just billed by another party. Our operating expenses were at 9.6%. It drops to 3% if you take our exclusions that we listed into consideration. And then our overall commercial rate increase, we're requesting 3%. So we've demonstrated performance the last few years. You can see our strategy is beginning to work. We are bringing patients back and strengthening confidence in our hospital. This is not new money. You see an increase in our hospital's financials, but it's not new money. It's money that's being spent somewhere else. And in most cases, the money being spent is larger than it would be had we provided the services. And again, I want to recognize our staff. The people that are part of our hospital family have demonstrated a remarkable resilience to the roller coaster ride we've been on with our hospital. Because, right there, while we were in the midst of Chapter 11, we also had a pandemic, and the hospital was really challenged during the pandemic and responded in a remarkable way to take care of our community, a very remarkable way. So we continue to be a low-cost provider. The savings from bringing care back are there. We're committed to serving our community and preserving critical access for everyone here. And I think it's important, for us to talk about as we go into transformation. One of the goals of this budget was to preserve our assets and our access to care that we offer. And many of those things are things that we've been growing and building over the last few years. And so we would like to preserve those assets as we fully engage in the transformation process, because we don't want to lose anything till we know how we're going to provide all the services of the future. So I think that's an important part of our budget, is that we want your trust around us, keeping our hospital as whole as possible as we go into that process. Next slide, please. So again, what happens, we know our budget is a pretty big ask compared to what other people might be asking for. But if we adjust our budget, we think it risks access and in our transformation work and reduces our future flexibility to participate meaningfully in that process. As we talked earlier, our social determinants of health here are about 2 points. Our patients are about 2 percentage points older, sicker, and poorer than state average, and that makes the work we do here even more important. You can see that by the large rise in charity care that we've had once Act 119 lowered the bar for that. A lot more people have qualified in the Springfield area, and I think that we understand why that is. And so we want to be part of transformation. We want to make sure that transformation improves access, improves quality, and reduces cost and leaves us with sustainable hospitals in Vermont as we go forward, because we know we have to do better. So with that, I'll close my presentation, and we would be happy to accept any questions from the board.
Thank you very much. I appreciate the presentation. I'll turn to Member Merman.
Great, thanks. Thanks for the presentation. There was a lot of clarification there for things that I had some questions on, and so I appreciate that. A couple of things, though, I generated some more questions, of course. So, Ms. Westcott, you mentioned about the AR days, and I had some questions regarding that. My understanding is that could have a pretty significant impact on your days cash on hand. What is a reasonable goal for your AR to get to, and what's a reasonable time frame to get there?
Sorry, I was trying to get off mute. I think generally, I would say 45 days is a good place to be for AR days, and we have a lot of work to do to make that happen. Like I mentioned, we're doing a lot of things to try to address that right now, and part of our cash being down, some of that, of course, is related to our AR being up. So if you have AR, higher than normal, that of course is impacting your cash. We've had, part of the reason why we've had our AR days increase, we've had a lot of billing turnover over the last couple of years. That's caused that to increase. We've had, Medicare Advantage issues with claims being, not processed correctly, working denials, appealing claims, stuff like that. So definitely have a lot of work to do to decrease that. But to answer your question, I think a good place to be would be 45 days. And it's an ongoing process to try to get that down. I mean, I don't see that coming down by, overnight. It's not going to be an overnight thing. It's probably going to take, a good part of a year to get it really where it needs to be, with a lot of work. I mean, revenue cycle is a beast. There's a lot of components to revenue cycle. So it's challenging for sure.
Thanks for that. If I remember hearing at the Gifford hearing yesterday, there was a mention of having support from RHRC. So I don't know if that's something you can talk with them about for working on improving the AR days, but they had a sort of different problem but had a similar impact. So another question I had for you was trying to understand, you discussed this large increase in charity care that's being provided, 2.3 million over budget, which I assume that's 2.3 million of gross charity care charges over budget. Is that right?
It's a combination of charity care and bad debt combined over what we had anticipated.
I'm trying to understand the impact of that on your revenue, essentially. So how to convert that gross patient bad debt charity care 2.3 into reduced dollars you would expect from revenue. Is there a way you can do that?
I'm trying to can you say that again? I'm trying to understand your question.
Well, I understand that charity care and bad debt are in gross revenue, not net revenue. And so I'm trying to understand when you're that far over budget in your bad debt charity care, what the downward revenue impact is on your net revenue.
So charity care and bad debt are a deduction of gross patient revenue. So you have gross patient revenue, and then charity care and bad debt reduce gross patient revenue to get to net patient revenue. So with charity care and bad debt being above what we anticipated by 2.3 million, that's reducing our net patient revenue by that amount. I'm not sure if that answers your question.
Yeah, I might try to figure out how to word it better and send it to you in a follow-up.
Okay, sounds good.
The other question I was very happy to hear about, I think it's an employee retention payment that you got, the recent one here in August, a few days ago. And I was wondering if you could just define what you think the impact will be on your 25 margin and your days cash on hand.
So the employee, yeah, sure. The employee retention credit was $5.6 million, which is about 30 days cash on hand. So pretty significant for us. We will be recognizing that in this year's and fiscal year 25 revenue. So that will convert the hospital to be, instead of having an anticipated loss this year, we'll have a positive operating margin. We're projecting of over $1 million with the employee retention credit.
Great. On a different topic, we talked a bit about travelers and travel. You know, this is a challenge for everybody and has been really before COVID, but exacerbated by COVID. That you were reducing travelers by 9 this year. I was trying to figure out what percentage of your total nurses have been travelers, say, this year and predicted for next year.
So right now, for travelers, we have 30 travelers. The nursing component of that is about 23. So a majority of our travelers are nursing travelers. As Bob mentioned, a lot of that conversion is happening here forward. So we haven't yet felt the impact cost-wise of the travelers, because we also have to let the current traveler contracts run out. Usually they're like 13 weeks. So a good portion of our travelers are nursing related. We do have some in rehab for physical therapy. We also have some in the lab, and we have one in diagnostic imaging for rad tech.
So when I was looking through the budget submission, it looked to me like I estimated about a 50% reduction in nursing travelers from 25 budget to 26 budget.
Correct.
Do you think that's a realistic goal?
We're hoping it is. I mean, we're quickly seeing the results of that. It could be a risk to get to that point, but we're already quickly seeing the results, especially with the nursing wage adjustments that we made in June. So we're already seeing employees that want to come work for us, which we didn't before because we weren't competitive with our wages. And now with our wage adjustments on the nursing side, I think we're in the 50th percentile for wages for nursing.
Yeah, we were successful in bringing candidates to interview, but we were not successful in getting job offers accepted before. And Dr. Merman, I think, Kata, would you just clarify for Dr. Merman his questions about bad debt and charity care? So year to date, the combination of those two things is we're about 1.6 or $1.7 million ahead of prior year on the sum of those two amounts. So a big part of our negative margin we're taking into the year to date was driven by those two buckets. So
yeah. I have kind of another question a little bit later I want to ask kind of in and around that topic, but another contracted staffing is this ED group. The ED and inpatient group, where are they being contracted from?
Okay, well, the new inpatient group is a group called the Rural Physician Group, and they're from the Midwest, and they have a core group of doctors who have been here now since May, the beginning of May, And their model's a little bit different. Their doctors stay in the hospital for a multi-day shift, and they sleep in the hospital and are on duty. They're sleeping, but on duty as needed. And then over in the emergency room, we were forced to have 2 locums groups staffed to ED because of challenges around recruitment until we could get a permanent group to assume the contract. And that will happen September 8th.
And where's that permanent group from?
The permanent group is from New York.
And is it a similar model as the inpatient group?
Pretty much. They will be here doing 12-hour shifts. That we're not expecting. We're trying to minimize 24-hour shifts in the emergency room because there's not much opportunity to sleep there. And so we're expecting most of those shifts to be 12-hour shifts and then replaced by one of their colleagues.
Okay. And then since now you bill the professional charges, then does your provider tax go up by that additional amount that you're billing?
Yes, it should. Yeah.
Okay.
Yeah, the provider tax will rise with our NPR, so we would expect it to. Yes.
Okay. And then I was looking through the productivity numbers. It seems that your physician group has generally low on the productivity numbers. I was just wondering if you could comment in regards to this and how that impacts your hospital budget submission.
Well, again, in 25 year to date, we've had challenges around general surgery because we lost a physician, back in the fall, and we talked about her exiting last year. We were just preparing for her to leave when we did our budget submission last year. So we have now replaced her and also brought one of our part-time doctors up to full-time, and so that has affected our productivity in general surgery. I think the other practices, gynecology is very busy, podiatry is very busy. I think everybody else is pretty busy. We did not have enough volume in orthopedics for the doctors we had. So now we've reduced one surgeon in orthopedics, and we're also reducing some call coverage with that too, because we just don't have a lot of call in orthopedics unless it's ski season here.
Yeah, I noticed that you're reducing your ortho surgeons, but you're increasing your budgeted ortho clinic visits.
Mm-hmm.
Yeah, we have.
That? Well, we had 2 doctors, and now we're going to have 1, and we have 2 physician assistants in that clinic also. So we have 3 people back there, and we had one of the PAs was working with our outpatient rehab program, and now we've brought her out of that back to the office.
So when I was looking through a lot of the materials that our finance team has prepared on all the hospitals in Vermont, Springfield looks like it represents about 0.5% of the total commercial spend for hospitals in Vermont, and overall is 1.5% of the total spend for hospitals in Vermont. And it does appear that you're in this complex position of having the lowest percentage of gross commercial revenue, the highest percentage of gross Medicaid revenue, and eyeballing it, one of the higher percentages of bad debt free care, charity care in the state. So to me, when I look at this, Springfield really appears to be the closest to sort of, what there's no definition of a safety net hospital, but you sure look like a safety net hospital. So I guess my question is, how do you manage long-term sustainability when you have a payer mix that is as challenging as you have?
Well, again, our strategy that has been adopted by our leadership and our governance has been to focus on the volume that we had a decade ago, and the volume that we lost during the hospital's troubles. We had a lot of really negative press, when we went through Chapter 11. We had a lot of scathing articles written, and we always seem to have a picture of the hospital that is covered in 3 feet of snow or something, and so we just got to get that confidence back. And we believe if we can do that, see, the problem we have is kind of our fixed cost here, and we've got to have more variable volume to offset the fixed cost. And so I think, so again, that's the strategy we've been following. It's been slow and it's been working. And of course, this year we've had some challenges around bad debt and charity care, and we've had some expense challenges as well. I mean, you know, I'm not sure what the other hospitals are reporting in terms of their pharmacy spend, but I mean, you know, we've had a lot of increases in drug costs. Some of those have been because of shortages. You know, so instead of buying through our normal supply chain, we have to go off contract because things aren't available. You know, so there's some of that too. But I think the big question, Dr. Merman, is you know, the way this has worked for us is, you know, is we do have a lot of poor people, and we've subsidized their care through commercial rate increases. And again, as we spoke earlier in this meeting, we've had 2 years in the last decade where we had no commercial rate increase. You know, so, you know, that we're carrying that forward as well. So how do we do it? Well, I think we have to get our patients back, or we have to look at our model, you know, very critically, you know, about the hospital. You know, what's the hospital going to look like, and how's it going to contribute? And knowing if it contributes less, then the care that people are going to get is going to be more difficult to access, and it's going to cost Vermont more money. So it's not going to save money. If we don't provide something, it's not going to save money.
Thank you for that,
Mhm.
Mr. Adcock. I'm going to pass on to the next person.
Member Holmes.
Great, thank you. And thank you all for the presentation and all the hard work leading up to it. I want to actually build on a few of Member Merman's questions. The first was in the area of the outsourcing of service lines. I just want to make sure I'm capturing all of this. So you currently outsource your ED, or you're planning permanently to outsource your ED. I know you're changing providers now, but ED, inpatient, looks like also anesthesia. Is that right?
Anesthesia's outsourced, correct?
Yeah. Nuclear medicine, is that also outsourced?
No.
No. Okay. I
No.
thought there was something in there. What other, besides ED, inpatient, and anesthesia, are there any other service lines or entire departments that are outsourced?
Well, just to clarify, those are the provider components of that, and not the whole department, just the providers, the doctors, and the mid-levels in those.
Yep.
Help me, Kate. Am I missing anybody? Pathology is out. Our pathologists are provided by UVM,
Okay.
and our radiology group is Dartmouth.
Okay, so that's great. I was going to add, was my next question. So radiology is Dartmouth, pathology is UVM. It sounded like inpatient was going to be a group called Rural Physician Group. What is the New York group for ED?
It's called Progressive Emergency Physicians.
Okay, and then
And they're
what is
from
the
Long
name?
Island.
Long Island. Okay, and what is the name of the group for anesthesia?
It's Collaborative Anesthesia Professionals.
From where?
From New Hampshire.
From New Hampshire. Okay. And as you're, you know, how do you find these firms? What is the mechanism by which you're finding these firms to contract?
Well, it's you know, there's a couple of things to look at. One, there are national providers, and our inpatient group is a local independent group that is contracted for overhead functions with a national provider. So the groups we don't have any national providers except for that unique situation with the ED group, right? So they're a New York group, and they have a national group that does their back office and administrative functions. So to answer your question is we basically, again, there's national groups who do this. I have phone messages all the time from people who want to take over my anesthesia, my radiology, that kind of thing. I get phone messages every week from people wanting to do that, but mostly we go by references. And the two groups that we brought in were people that were referred to us by people that, you know, we asked them who they thought would be good for our hospital, and that's how we found them.
Are any of them owned by private equity?
No. The anesthesia group is owned by, I believe that the principal of that group is the owner, but he's not private equity.
Okay. Do you know
Some of the national groups are, though.
that you contract with? The one that's
No, I'm saying in general across America, some of the national groups are owned by private equity.
Yes, no, that I know.
None of ours are.
Okay. How are the providers compensated? Do you know if it's a strict fixed salary, or are there variable incentives in there related to productivity or quality of care or anything else?
The inpatient group has an RVU bonus in their contract. Anesthesia does not. It's basically a cost guarantee for the program. Pathology and radiology, they bill separately. We do pay a small fee to UVM for them to serve as the medical director of the laboratory. There is a small fee for that. So the inpatient group has an RVU bonus, and I don't remember about the ED group since they haven't started yet. The locums doctors that are providing now do not. They just get paid a fee for the work they do.
Do you know if there's any incentive built into their contract for quality of care?
That is one of our quality pathways that we've been focusing on, because we believe that we can do a better job around overseeing the quality of those providers. And with the new contracts, we're going out of our way to set tighter and greater expectations for the quality monitoring and the information that's reported back to the hospitals.
Okay. That leads into my next question. With so many of your core services outsourced, I mean, I was surprised by how many of them are outsourced. I'm wondering how you build culture, how you ensure continuity of care, how do you ensure quality of care when you don't ultimately really have management control over the providers that are in your facility in the way that you would if you staffed them yourselves?
Well, 2 points, and they're both things that we're focusing on improving. So, of course, our quality pathway, this is part of our overall quality pathway for the hospital, right? We know we've got to improve the quality of the services we provide, and that's why we're placing greater quality expectations and greater quality reporting on the new groups going forward. In terms of education and training, the place where we are making strides right now with the new groups is improving the orientation and education process so that they have better training on how to use our EMR, how to do things at the hospital, get things done, who to call for what, and those kind of things. So when you constantly have doctors that are coming and going, it's hard for all the doctors to be familiar with those processes. And so that's an area of improvement for us now. We're spending a lot of time as a team with that orientation and training piece.
Yeah, and I guess what I'm trying to understand here is it looks like you recently converted the outsourced inpatient rehab back to Springfield staffing. Is that right? It used to be an outsourced provider contract group, and now you've hired within?
That's correct. We had a split model here. Our outpatient therapists were employed by the hospital, and for the inpatient side, we had it outsourced. And we thought it was better to have one program and have it consolidated so we could move people around and have the flexibility to be more efficient.
So I guess what I'm trying to understand here, thank you for that. I mean, this is a new area of inquiry for me because I don't understand it all. And so thank you for your candid remarks here. I'm trying to understand, like, when you're deciding to completely outsource a service or alternatively to take back a contracted service, how do you balance the financial benefits of a decision in either direction with the quality continuity of care? How does that all, what are the criteria that you decide, okay, this one we're going to completely outsource this versus this one we want to take back in? How do you make those decisions? It seems like there's been some changes, a lot of changes at Springfield over the last few years in this regard.
Well, I would characterize the rehab change as pretty small. The therapists that were outsourced on the inpatient side, it was 2 people. Right. And so those 2 people, one of them exited after the contract and one of them stayed on to do some per diem work for us. And so it ended up being 2 people. And
yeah, but also even within, you've outsourced ED, but you're changing the provider, the vendor. So I'm also just trying to understand, what are the factors that say this is outsourced, this isn't, or we need to change vendors for this particular service line?
That's a tough question. I think for those type of programs like the emergency room providers in the inpatient hospitalist and those type of things, one of the key considerations there is they have access to providers and they have groups of doctors in mid-levels that work for them and are familiar with them. And so when people need to go on vacation or they get sick or out unexpectedly, they have bench strength to cover those shifts. Whereas if those people worked for us, it would be a big lift. We'd be resorting to a locums firm. We'd be calling locums and paying much greater amounts to cover those shifts. And then it would be on us. And now when one of those groups has an opening, it's incumbent upon them to fill it because we have an agreement that they've agreed to staff the department for us. So it's not. And again, here, those departments that we have anesthesia, pathology, radiology, the hospitalist, ED, those have all been outsourced here for many years. And they also have been outsourced at most of my other hospitals throughout most of my career because of those reasons.
All right, thank you.
I'll just tell you that the Dartmouth group, if you have an X-ray at our hospital, it goes electronically to Dartmouth and is read very promptly by the last time I looked, there were 106 Dartmouth radiologists credentialed on our medical staff to read those films. So your X-ray from Springfield gets read at Dartmouth almost immediately, and then the result pops back up in our EMR when the result is released. So very good service for our patients and the attendings.
Yeah, no, great. Thank you. I appreciate that. Another area, your financial sustainability plan seems to really focus on recapturing market share, from New Hampshire and other places. But it really seems like the success of that endeavor is going to depend on the payer mix of that recapture. But from slide 13, it looks like from fiscal year 24 to 25, when there was a large effort to kind of recapture and keep care local, it looks like you're seeing a decline in commercial. It's hard to tell what the net effect on Medicare and Medicaid is, but it looks like it potentially could be high. And we know your charity care is definitely up. Mm-hmm. So as you're thinking about your sustainability plan going forward of recapturing market share, have you done an assessment of Springfield's ability to recapture the outmigration of commercially insured patients? Because that's going to help your margin going forward, right? Is capturing the patients that are going to cover the costs of Medicare, Medicaid, and the uninsured. So have you done an assessment of that?
Well, not specifically, but we believe that the market share we've lost, we believe that market share has better insurance coverage than the market share we're keeping because that group is more mobile and has the ability to access care further away geographically.
Right. And my worry is, are you going to be able to recapture them or not? And it looks like from the 24 to 25 numbers, there was a reduction in Blue Cross and commercial from 24 to 25 in terms of the payer mix. So
Well, we have some challenges, around Blue distinction. We're not in that program, but yeah, I mean, we do have a challenge payer mix. But if we bring back as many patients as we can, we're expecting a rising tide to float all boats.
Okay. Some of the service areas, this is where also on member Merman's questions around productivity. He did highlight some of the clinical productivity. It looked like it was ENT, it was urology. They were under the 10th percentile. Podiatry, I know you mentioned as being busy, but it looked like it was between the 10th and the 25th percentile. Where do you target compensation wise for these areas? Do you try and target? Do you match productivity with salary or no?
The only physician group that has any RVU impact is in our orthopedic group. And again, the volume has been down there. The other providers we have are basically hired on a per hour or per day basis.
Okay. And what is the target percentile that you target their compensation? What percentile target?
We basically look somewhere around the 50th percent of the MGMA. whatever the median is there. So we try to be very, we're certainly not going to be the highest paid physician practices either here.
Okay.
But we have work to do around that because, some of our information systems are not as robust maybe as some other people have. So we don't have a large variable compensation model that's operating. And some of the providers you just mentioned, like urology, is a part-time service. They're here approximately 2 days a week. And then we
Are
have
there any plans to introduce variable pay, productivity-based pay in some of these areas?
I mean, it's not an initiative that I'm working on. I mean, I suppose if it becomes necessary to be competitive, that we will do so. Also, other than urology, I wanted to mention, that ENT he's in solo practice here. So he's the only provider we have. So it's one person. We have restructured his hours so that his office visits are now up because we've rearranged his hours a little bit during the last year. So I think you're going to see his increase.
Okay. I guess this is my last area of questioning is just, can you talk a bit about your conversations with RHRC and AHS? You mentioned that some of the recommendations that they've made are consistent with directions that you're going in, others are not. Can you talk a bit about what they have suggested to you for improving financial sustainability and what, your views on their recommendations?
Well, I'll say right now, I don't think we have any recommendations from them on how to improve financial sustainability. We haven't had any in-depth financial analysis from those groups around the overall strategic, directions that are being suggested. So I think that that's going to be an important next chapter in this reformation work are the things as we evaluate these things, are they going to accomplish those goals? Are they going to make the hospital more sustainable financially? Are they going to lower cost, improve access, or at least keep access a level playing field? I mean, those are important considerations. We do not have any detailed financial analysis on those suggestions currently. So I don't know. I don't know. What I will tell you is that over the last couple of years, we've evaluated some things that we think we needed to know. Like, for example, we did evaluate whether we should be a rural emergency hospital. And when we did our own analysis of that, did not support that. I mean, the hospital did not do better financially, and the care we would have sent to somewhere else would have still been paid for by Vermont. So it didn't achieve either of those two objectives when we analyzed it. And we did that about maybe a year and a half ago, almost, probably at least a year and a half ago. We were doing that as Oliver Wyman was doing their analysis, and they were talking about the REH model. We undertook our own evaluation of that.
Right. Okay. I just want to confirm any assumptions built into this model, into this budget around elimination or reduction in service lines. I'm asking all the hospitals, so if you can just confirm any assumptions that you're making in this budget around either elimination or reduction in service lines.
No, not other than the ones that were already in the presentation. I think that's one of our important points that we want to make as we go into this process. We want to have all of our assets and all of our weapons, so we can contribute fully. And if we start changing service lines and reducing access and reducing programs now, then we may find out later on that should have been something that was kept.
Yeah.
Right. And in the areas, think about our areas. I mean, we think we need to grow mental health here. We think we need to offer more mental health services. So how do we do that? We think our adult daycare program saves money because it keeps people out of nursing homes. And we think it's a saver.
No, important parts of our care transformation that I know.
Yeah, so we want to have our whole box of tools when we go into this discussion. As we do the analysis that you just asked me about, as we do that analysis, we want to have everything to bring to the table. We don't want to scale the hospital back and then not have anything to bring. I mean,
Well, one final question actually about that. Are there any, given some of the productivity numbers around some of your specialty areas, have there been any conversations with neighboring hospitals about sharing specialists?
Yes, yeah, we do that all the time. I've tried for a couple of years to share cardiology with some of our neighboring hospitals, and we've not had any success with doing that, although we've talked about it quite a bit. Um, we have had discussions about sharing other doctors, but it's a challenge because we also have to get the doctors to agree to do those things. You know, and there may not always be. We had another one of our colleague hospitals that I won't mention, I won't identify, but they contacted me recently about sharing some of our doctors for on-call. But if that doctor was here in Springfield and they got a call back at that hospital, you know, they were going to have an hour drive in a Vermont winter to get to the other hospital. You know, so the only hospitals that are really close to us are very close to us are Valley and Mount Scottney. So,
well, I think there's some hope that some of these regional planning conversations can look, you know, more globally at sharing services across different hospitals. So hopefully there's more opportunities in the future to lower costs and retain or even improve access in some areas. But I will end there. Thank you very much for answering my questions. I actually learned a lot. I really appreciate it. So
okay, thank you.
Member Ticho?
Thank you. I have mostly follow-ups, maybe from a slightly different angle to what you've already been discussing. I very much appreciate you simplifying the billing for patients with what you discussed about you taking on the ED billing so that patients are getting one bill. Can you talk about what's happening with the other areas where you have outsourced services, such as pathology, radiology, some of the other ones? How is the billing working there, and how many bills does a patient receive?
Yeah, right now we do have separate billing with radiology and pathology. So we do have
Okay.
that. So with this consolidation, the inpatient hospitalist group and the emergency room group, the patient will be getting one bill. And I think the emergency room is a place where it's confusing because you have somebody comes in for a simple visit and gets a couple of bills. They probably are going to get 3 bills. They're going to get one from the doctor, one from the hospital, and one from the radiologist. Probably won't see pathology unless they have a specimen from the OR. But you know, I don't think we're having as much confusion around the rest of those.
So if
Wait,
someone
in a-
goes into your ED and has radiology read at Dartmouth, they're going to get a separate bill from that?
They'll get a bill from Dartmouth. That's correct.
Okay. Did
They
you
would
have
also
something
get a
else?
bill if there was, just as referencing an ED patient, if they had to go for emergency surgery, the anesthesia would also be, they would get a separate bill for anesthesia as well.
Okay, so just to clarify again, what you've consolidated is only the ED billing, not the pathology, not the radiology, not the anesthesia?
Correct.
Okay, thank you.
Yeah, it's just the
Um,
ED professional fee. Yes.
Okay, so this may seem a little bit naive, but when we are approving a rate increase, does it apply to all of these contracted services?
Not the ones that are outsourced because they're doing their own billing. So only the services that we provide and are billing for.
Okay, so just to be super clear, pathology is UVMMC. Those will not go up by 3% or whatever percent. I can't remember what we're looking at right now. Whatever we approve for your facility.
Whatever you approve for us will not apply to pathology, to the radiologist at Dartmouth, to anesthesia will not apply to them.
Okay, but they will go up by whatever we approve for UVMMC because they're
I
under our
believe that's the
jurisdiction.
case. Yes, they would not go up by our increase. They would likely go up by that hospital's increase.
Okay, and then there's some that I'm talking about the Green Mountain Care Board does not control. So whatever happens at Dartmouth is what you contract or what Dartmouth tells you they're going to increase it by? What happens there? Or is it the contracted rate with the the person's insurance plan. So say they have Blue Cross and Blue Shield of Vermont, it's the contracted rate that Blue Cross of Vermont has with Dartmouth. What happens there?
I mean, without looking at the contract, I'm sure it has some language in there that the bills have to be reasonable, but I think the second point you made is probably correct, that, whatever that plan is negotiated with our employees. I know if I have an X-ray, Dartmouth reads my X-ray, and then I get an EOB that shows what the charge was and what it was adjusted down for our insurance discount and what insurance paid and then what I owe. So, that's what my bill looks like. So,
okay, great. So pulling in, just to keep following this a little bit more of the way through. So pulling in the ED billing to you means that it'll go up by whatever we've approved for Springfield, or not, because it's still going through your outsourced vendor.
Well, it's now in-house by the hospital now, so it will go up by the percentage that we've requested.
Okay. Okay, great. Thank you. Just, a few things I didn't quite understand about how all that was going to work.
and just to clarify, and this also goes back to Board Member Holmes's questions. The practice in the industry is to outsource many of these programs, and it's been that way. Most of the services in most of the hospitals I've been in my career, we had all those those professional services were outsourced to another group. On very few occasions were they my hospital employees, and in most cases they billed separately. I think that this is just a particular area where we thought it would be better for our patients if we brought it in-house. So, but what we're talking about is not an unusual. I mean, it's a very standard practice, is what that we're talking about. So
yeah, I agree. I understand it's standard. I also understand why patients are so confused when they start getting their bills. So,
I get confused by my bills sometimes. So,
and then one other thing I wanted to follow up on was your 340B program. Are you anticipating any major changes in the revenue you're able to get through that?
I think the answer is that we're not. Is that correct, Kata?
Yeah, we are not, as a critical access hospital, the Act 266, I think it is, does not apply to us.
Okay, so Act 266 and 340B are different.
I might have gotten my acts confused.
Yeah.
Both of those issues are in Act 266. The 340B is the contract pharmacy issue where, and then there's the cap on the price at 120% of ASP, which I think does not apply to you. If you can't answer it now, I'm happy to write you a quick follow-up.
Sure, that would be helpful.
I'll do that.
I know our 340B contract pharmacy revenue is very minimal. We have about 40,000 a year. I think that's budgeted for 26 on the contract pharmacy side.
I think I did see that. And where is your pharmacy located?
At the hospital.
It is in the hospital. Okay. Those are all my questions. Thank you for your answers.
Thank you. Member Walsh, are you available? I know you're having some technical issues. I can go ahead with a couple questions. Do you have a contract with Ovation still?
We do.
And can you describe what services Ovation provides?
I will, yes. Ovation is a company that consults with us, and the primary service we get from them is some financial consulting that supports our financial function. Also, one of their executives consults with myself and members of our governance. So it's a small contract with that group.
How much is the contract?
I would prefer to share it with you offline, not make it a public record.
Well, I think you normally file it on your 990s.
Do we? I think
Well, so your
then
990s, you have to report your largest contracts. I know it was in one of your contracts in prior years.
It wouldn't fall under our top 5 highest paid contractor contract cost. So
Okay.
I don't think it would be under 990. I'll leave it up to Bob though to.
well, I would prefer not to answer it in public session, but I will tell you that the total amount of that agreement is less than $100,000 a year.
Okay. And is that generally how much it's been over the last several years, or has it gone up and down over time?
Well, Ovation and their predecessor company was the company hired by the hospital to take us through Chapter 11. And so that contract, they actually had a CFO and a CFO running the hospital prior to Kata and I being in those roles. And so they were basically the restructuring officers through our Chapter 11 process. So it has been higher in those days. And occasionally we will purchase some other consulting service from them, but it's not very common that we do that. Like we may have something looked at, but it would be a separate scope of work but the ongoing services they provide, the primary bulk of those is the work that they do assisting CADA with our, CADA, you may have to help me describe what those services are. It's like our rates and how we calculate those and things like that.
Yeah, a lot of the net revenue side of things. We have a small finance department, so they help us with a lot of the net revenue side of things, including the budget, and that portion of the budget. So that's primarily what we use them for. But to answer your question, over time, our costs with Ovation have significantly decreased because when we contracted with them with a CEO and CFO, the costs at that time were pretty high.
So it used to be that the CEO and CFO were quorum employees, but now it's not. Is that what you're saying?
During our Chapter 11 time period, they were quorum employees.
Got it. Okay. And then do they have any input, or do they converse with you at all about which outsourced provider groups to consider?
That would only be if we would engage them in that discussion.
Have you?
I don't believe we have. The last couple of departments we've changed, they were not involved in those.
Okay. To your knowledge, have they ever been involved in discussing, which third parties and outsourced services to use?
Not in my discussions unless we solicit their advice. I'm not sure what you're referring to.
Yeah, I'm just asking generally, does Ovation have any discussions with you ever, to your knowledge, about selecting outsourced groups?
No, I have not consulted with them on any of the physician groups we've hired or changed during the time I've been here. Now, in the discussions we have between leadership and governance, we may discuss those changes with them, but they would be decisions that rest with the hospital and the board, not with Ovation.
Right. So you advise, they're part of the conversation and know of it, but they're not influencing it or having any input in the decision-making process, right?
No, those would be hospital and board decisions.
Great. Okay. I think that's all I had. Member Walsh, did you have any questions? I think you're muted, Tom. I think Tom was having some technical difficulty. So what we can do is, if Member Walsh has any other questions, we'll send them in follow-up.
Be glad to respond to those.
Great. I'll turn briefly to the healthcare advocate.
Hi, thank you, Chair Foster. For the record, I'm Charles Becker, staff attorney with the Office of the Healthcare Advocate. Mr. Adcock and Ms. Westcott, just want to say quickly, thank you for the presentation. And also I wanted to offer some appreciation for the success you're apparently having with your Act 119 implementation. $3 million in free care or double what you had budgeted. I know that adds pressure to your hospital's bottom line, but for those members of your community receiving that care, I'm sure it helped many of them to keep their households' finances above water and to get needed care. So I'm sure that was incredibly impactful for them. And so just on behalf of the HCA, good work on that. Following up on some of member teach-outs questions related to 340B, I had a few questions myself, and so I'll just sort of work through here and see what's not duplicative. Because in my mind, at least, 340B and Act 119, there's a plausible connection there that, at least to the extent that 340B revenue could help you to offset some of the pressure on your margin related to providing free care. And so, I looked at your 340B data in the supplemental workbook, and I think I heard you say just a few moments ago that the contract pharmacy revenue in particular is pretty minimal. And so my question is, well, I had two questions here. Could you just say a little bit about how Springfield Hospital manages its participation in 340B? Do you have a strictly in-house people managing it, or do you work with any vendors for 340B management?
Well, we do have a pharmacy director who and a resource person that works with him that's very experienced in working with the program. So they do the bulk of the daily work. I do think we have a consultant that comes periodically and evaluates our program, and I'll turn to Kata to see if she can confirm that. We do have somebody that comes in and looks at our program and makes sure we're following all the guidelines and the rules and complying with all the rules.
I think that's correct. I can't even think of what the company's name is, but I think they do like mock 340B audits to make sure we're in compliance during the year. I don't know enough about that to speak about. We'd have to probably consult with our pharmacy director if you wanted more information.
Sure, and maybe this is something if a member teach-out was so inclined to include in her follow-up questions. I mean, it sounds like she was interested in this same idea. I mean, so, compliance, of course, you want to make sure you're compliant. I mean, I think another thing for a hospital that's struggling with revenue is maybe potentially wanting to know that you're not leaving any 340B money on the table. Has Springfield Hospital assessed whether there's opportunity for you all to grow your 340B revenue, particularly with the contract pharmacy protection languages that were passed with H266 and that are in effect, at least for now? I mean, has the hospital assessed whether there's room to grow here and draw down additional revenue?
Bob, do you want to take this? Or?
No, well, I think we look at the program all the time. It's obviously important that we feel comfortable that we're complying with all the regulatory burden of it, which shouldn't be underestimated, because to be in the program, there's a lot of work that has to be done for us to participate. And we have looked at are there ways to improve our performance. But one important thing to note with our 340B participation is that all the primary care practices here are affiliated with our local FQHC, so they're not part of the hospital. So a good bit of the revenue goes in that direction, and that is important revenue for that organization because, like us, they also have really tight margins, and so they need to help to keep their access point going as well.
That's a good point about the FQHC. Yeah, absolutely. And yes, I'm sorry.
Sorry to interrupt. No, I was going to make a comment that, so we have, and I am not a 340B expert, but we do have minimal, like I mentioned, minimal contract pharmacy revenue, but we also have 340B. We're in a mixed use program, which means we have cost savings. So that's where we have the most benefit, is from a mixed use program where the cost of the drugs are a lot less if they're 340B eligible. So on average per year, we save about $600,000 to $700,000 in cost savings on the drug. So it's just less money that we're paying to the manufacturer, to the drug manufacturer. So that is the most, more of a pickup for us than the contract pharmacy side of things.
Sure. No, that makes sense. And I had noted that source of revenue too in the supplemental workbook. I'll leave it at this for my questions. I mean, I just, again, to sort of reiterate the point, several times in the narrative, there was an emphasis on how much the free care was, a struggle for you to be able to keep up with that, and just thinking that maybe 340B is a way for you to sort of bridge the gap there, if you possibly can. So thank you for that.
Thank you.
Okay, and just one other clarifying question, just to make sure I have it right. For the outsourced services, none of those outsourced services you mentioned, ED, inpatient, anesthesia, pathology, radiology, none of those are subject in your mind to the care board's rate caps, correct?
Well, if they were billing separately, they would not be.
Right, which ones of those, can you tell me which ones are billing separately?
Anesthesia, pathology, and radiology.
Okay, and ED and inpatient is not billing separately.
Yes, yes. Kata, would you clarify for me, please? Because we did change the emergency department. That group, the prior group, was billing the emergency room separately. And so
you have that correct.
Yeah.
We are doing the billing, the hospital's doing the billing for the ED and inpatient. Those are contracted, but we're doing the billing, so they're subject to the Greybound Care Board. But the anesthesia, pathology, and radiology, we're not doing the billing for those areas. The provider is.
Okay, and then in terms of the care board's NPR cap, which of those outsourced services are subject to the care board's NPR cap?
Well, for the ones that are billed separately, I would presume the only one would be UVM.
Correct.
But this, you've given us some food to think about here, I think.
Yeah, us too. Okay.
Chair Foster, can you hear me now?
We can, yes.
If I could just ask a couple follow-ups here, because I think these aren't part of my prepared questions, but Bob, welcome back. You've worked a lot of other places. How common are the use of shared services or fractional services in hospitals of Springfield's size across the country?
Well, there's a great deal of variation about how different hospitals do different things. I've been in a couple of larger systems, and some of those systems had hospitals that were grouped in regions or in close geographic distance from one another. And so it was very common to share overhead departments, or you might share IT, or have a combined purchasing department, or it was very common to share those type of services in those arrangements where the hospitals were close together. In some of those hospitals, we also shared medical staff members too. When the hospitals were close together, we may have common providers at the medical staff level as well.
Right. And so those outsourced, the companies that you are outsourced to, they could be independent, or they could be aligned with a larger hospital system.
They could be. For example, as we treated radiology, when I arrived, we had an independent radiology group that was, and I suppose they were probably a national group. I'm not sure what the scope of that group was. They probably had a lot of accounts. And with radiology, as digital and electronic transmission of images has evolved, that's become pretty common, right? You can send an X-ray anywhere in the world and have it read these days. But anyway, when we changed that group and we went to Dartmouth, and again, we have the service and the quality from Dartmouth has been above reproach. So.
Yep.
Mm-hmm.
Well, in my experience, the outsourcing can be an independent company, and radiology is a prime example. It could be anywhere around the world. but there are larger health systems that do the outsourcing. And these arrangements become more common in regionalized areas like our state is perhaps looking to. And the point that I think is important is if a hospital that we regulate in our state provides those services, that organization would fall under our caps or limits.
Mhm.
But if that company or hospital is outside of Vermont, they would not. That's, I think, the key point in some of this, that the arrangement that you're describing at your facility with these outside groups pitching in or helping out is not uncommon. They become more common in regionalized approaches. And the companies that provide those services can be independent, which would be beyond our regulation. They can be from hospital systems outside our state, which would be beyond our regulation. Or they could be from hospitals within our state that you're sharing services with, and that would be within our regulation. I think that's a key point, and I'm not sure that it was getting across like that. So that's all. I think what I saw from your submission, your quality is getting a little bit better. Your utilization forecasting seems to be getting better. Your OpEx is still gives you some challenges, but overall, I think that my read of things, the trend coming out of the bankruptcy, you're on a good trend for a small hospital, and making sure that you align any growth, whether it's from a new surgical provider or any growth, making sure that's aligned with your community health assessment is a key thing that I'll be looking for in future budgets.
Well, I appreciate you recognizing the progress we've made there. There has been a lot of hard work here, and a lot of people have made a lot of sacrifices to stay on the team and keep pulling on the rope here to provide the service that we provide. So, I always want to recognize because I don't really have much to do with the day-to-day success. It's all the other people with the work that they're doing to make a difference. It's not me, it's those guys. So they deserve the credit. But it's been a long, challenging road for us. And some of the things that we're dealing with now are things that the hospital didn't have money for several years before the Chapter 11 event, like keeping the equipment up to date, fixing the building and the plant and the infrastructure. Those were problems that didn't start just on day one when they declared Chapter 11. So we're having to go back and address a lot of those things. And we appreciate the board's patience with us as we work through that. But it's been a hard year for us, and the bad debt and the charity care has had a big impact on us, and also the expenses that we could not control. So our volume is rising, and we're having challenges recruiting, and we have costs rising that we can't control, and so we're really stuck in a kind of a hard place here. So
Yeah, I hear you. Thanks for all you're doing, and that's all I have, Chair.
Great. If you're out, so when we give a NPR cap, it's with a presumption that the services that were in the budget presented to us will remain. But if you move services out and it's now billed separately, you're increasing the NPR cap effectively.
Yeah, I think that would be correct. I mean, if I wanted to artificially lower my NPR, I could go to all my outsourced contracts and say, I want you guys to take over the billing. I'm not going to do it anymore.
Yeah, I'm not even saying it's like artificial or necessarily wrong, but it has an impact because if I think you said you changed ED mid-year, so the anticipation was that the utilization was what was submitted, and that would be under the NPR cap. So if you move it mid-year, our NPR cap is now higher than we had wanted to do.
Correct.
How would you suggest the board think about this. I mean, the caps are there for a couple reasons. One is, a major task of ours is to keep track and try and contain healthcare costs. And this may not be just for your hospital, it may be more applicable to somebody else's, I don't know. But so, effectively, it nullifies the impact of the NPR cap. We want to contain the costs. We may even want to encourage costs to be moving elsewhere to lower cost providers, moving the care out of the hospitals. So some of that is nullified if that cap becomes not where we had targeted. How do you think we should think about that?
I think, and this is a more general statement. It answers your question, but I think it's a more general thought that we should talk about, and that is how we communicate with the board on some of these. I can see that we need to communicate with the board more frequently probably than we do. And as I've spoken before, first couple of years I was here, we had a monthly meeting because we were like coming out of Chapter 11 and the hospital was so fragile financially. And, that I felt like that was a good process because everything we were doing, we were sharing in that meeting. So there weren't any surprises because we talked about what we were doing every month. So basically a mini operations review that we did with the board.
Yeah, something to think about. Okay.
But certainly I can see as we've gone through, and we're also working on that other challenge we have around our FY24 net patient revenue increase. We really see that we need to evaluate the way we're communicating when these things are changing to be sure that there are no surprises for you.
Okay. All right. Well, thank you very much for your testimony today and for the presentation and the work on your budget and for all the work you are doing at your hospital and the community. I'll turn to public comment via raise the hand. Lynn Raymond Empey.
Close. My name is Lynn Raymond Empey, and today I'm here as a patient of Springfield Hospital. Not so long ago, I had a pretty bad health issue. I had to see a specialist that was located in a New Hampshire hospital. He thought I needed to be admitted, and so I went to the New Hampshire hospital. But I'm a resident of Bellows Falls, Vermont. And so when I went there, I immediately was hooked up to IVs. Things were a little bit serious. But the issue became that they were code red, and this was not Big Dartmouth. And so they had no rooms available to admit me. And so I had to be transported. I was on Blue Cross Blue Shield insurance, and I had to be transported. And they were trying to find a place to send me. And Springfield Hospital at that time didn't come into the discussion. But of course, I said, well, why not Springfield Hospital? It's right close by. They should be able to keep track of me and handle my case just fine. The specialist agreed. And I got transported there at a cost of $2,200 from basically southern New Hampshire, just over the border, to Springfield Hospital. My insurance company paid about $500 of that. The rest of that was supposed to come out of pocket. I had to appeal it. It took about 1.5 years, but we finally got a check back for a little bit more. So from the patient side of this, from now on, I go to Springfield Hospital first, and they have been terrific at consulting with specialists in New Hampshire, working out a plan of care, working out a discharge plan, dealing with my care, setting up additional appointments. I can't say enough good about them. I think they are the little engine that could in a lot of ways. And I hope that they are a model for the rest of the state. I think they've done a lot of work there. It's an extremely clean facility. I mean, it's probably one of the cleanest hospitals I've ever been in. I thought the staff was great without fail, whether they were traveling nurses or whether they were regular full-time nurses. And I appreciate the care that we were given. And I hope that as you go through this process, I think about the number of people that are here representing Springfield Hospital today, and I see 2 people, And then I see other people who are associated with Springfield Hospital, but it's a small admin team. So as the Green Mountain Care Board begins to, to help go through this transformation process and the budget process, not everybody has a team of administrators to meet the administrative burden. And I hope the Green Mountain Care Board gives some consideration to that in the future. Thank you.
Thank you very much for your comment, Ms. Raymond Empey. Any other public comment?
Oh, and if I might, I hadn't realized that we were going to have public comment because there are 3 legislators on this call, and oh man, I'm gonna cough. Classic. Hold on, I'll be back in a minute.
No problem. Get a glass of water, and thanks for being here. Any other public comment while we wait for Senator Clarkson? Okay, we'll just give her a moment.
If I may, Representative Christy Morse here from Springfield, North Springfield. And if I may comment, follow up to Lynn's comments about transportation. I appreciate one of the former members or questioners mentioning that Springfield Hospital is a safety net to much of our regional population, especially the elderly and those most in need, which is driving up some of the expenses. I understand that. I'd just like to add in that when Lynn tried to go to a New Hampshire hospital for treatment, they didn't have a bed for her. I also work for Springfield Fire and EMS on a part-time basis. I'm not a full-timer anymore. I aged out. But I do know that we transport a lot of patients out of Springfield to try to find a placement bed. We use Albany, Bay State, Dartmouth, UVM. They go all over the state or all over the region to try to find a bed. And I think it is important that Springfield maintains a presence here to operate and treat the patients that we are seeing, that we can do with some of the services. And this would just drive up the cost to transport them elsewhere to another facility, and often at a higher cost. So kudos to Springfield for coming out of bankruptcy. The 3 representatives and senators that we have on board with us today for this session have been working or talking with the administration at the hospital for years to try to understand this. And it is such a valuable asset to this community and this region. It's not just Springfield, but for this region. And it's important that that's understood that if we have to transport elsewhere, those costs are going to be driven up. A follow-up on that is the Springfield Fire EMS also does transportation when we have availability of units, and we have a non-emergency transport unit that's was added in a couple of years ago, and there it's taxed, it's overburdened with transport systems, and if we have to transport elsewhere, those costs just escalate. If we have to transport to these the facilities that I mentioned, such as Albany, Bay State, Rutland, UVM, Dartmouth, and then the local impact is that when our units go out, we have to backfill or backstaff, call in supplemental staff at time and a half, and so it drives up our local budgets, which is an impact that perhaps the hospital is aware of, and Green Mountain Care Board certainly should be aware of that. But it would have an impact on Springfield for these outsourcing patients to other facilities. And I just don't want to lose sight of that. Thank you.
Thanks. Thanks, Christy. Well said. Allison Clarkson, I'm not only the senator for one of the 3 senators for the Windsor District, but I'm the chair of Senate Economic Development, Housing and General Affairs. And I think one thing the Green Mountain Care Board with all their hospitals should do, partnering with Tuck maybe, Dartmouth Business School, is an economic impact study has to be done on these hospitals. I would speak to, I mean, I think the care has been well spoken to. I think two things with Springfield. One is it's an invaluable resource to this community. And two is we need to cut them some slack coming out of bankruptcy. They've done an amazing job coming back and becoming a really strong, viable presence in our medical community and in our community, period. And I'm so proud of them. And I think Bob and Kate have done a splendid job. But I think one thing we're failing to take into consideration is obviously the medical care and costs are critically important, but also the cost to our community. The economic driver this hospital is in our community and in Springfield is I would say it's hard to measure, but there is a measure, and we should be doing economic impact studies for every one of your small rural hospitals.
Senator Clarkson, I think that's a great idea. You may see me in a few months asking for some money to do that.
Maybe Owen, you and I could meet in the next couple months and figure out some places we might look to for that money.
Yeah, I think it's a great idea. I think there is a piece of that that's very valuable.
Obviously, healthcare costs have to get reined in, but also we have to look at how important these hospitals are to the whole economic fabric of our communities. That health and economy are all obviously woven together very tightly.
Thank you. Any other public comment? Alice Emons?
Yes, thank you. I want to thank all the members of the Green Mountain Care Board for your thoughtful questions and listening, and also for our hospital folks, for Bob and Kata. You did a great job. One thing that I really want to emphasize is our community in Springfield, on top of what Representative Morris and Senator Clarkson, I'm the other representative from Springfield. We have an aging community that really depends on a healthy hospital that is in our community. Many folks in our community do not have access to transportation to go to a healthcare facility further away. And you were also concerned about the charity care, the debt, bad debt. If we close a hospital in this region, these folks aren't going to go away. They still are going to need health care, and it's going to cost our system much more. We have a poor community. We have a community that's aging, and our hospital is so vital to the economic stability of our community, but it's also so vital to our community members to stay healthy. And I just want folks to put that into the balance. And I just wanted to share that with folks because we're talking about people's lives here. And not everyone in Springfield has access to get into a vehicle and drive 30 miles for their health care. They just don't. So I just wanted to relay that. And I want to thank you all for your questions and for your thoughtful deliberations. Thank you.
Thank you. I think these are really good points, and what we struggle with every year is how do we keep it all going, right, in this environment. And money here is money not there, and money not there is money not here. And it's something that legislators, you all deal with in your work, trying to prioritize it and really keep the balance right. And it's a struggle every year for us to get it right. And we try our best, and I appreciate the feedback because it's really important to that decision-making process. I just have a first name, Marty.
Yes, I'm the administrator for Greater Rockingham Area Services. We are the entity that manages the building that houses Wyndham Center, Springfield Hospital's mental health unit. I'd like to echo what Ms. Emons just said in asking you to please consider the ripple effects of Springfield Hospital. And you've heard from a lot of Springfield people, but I'm going to talk from a Bells Falls perspective. We also house North Star a federally qualified health care center. And they chose to consolidate and pull primary care, behavioral health care, and pediatric care out of our community. It has been a big hit for our community. And talk about economic driver. That was one of I recently I had to apply for some grant funding to help us do some work here. And that was one of the things is this building is an economic driver for our community, and we need to keep this building viable. So I would echo what Ms. Eamon said, and I would urge you to think about repercussions, the ripple effects of closing, of regionalization, of those type things, because I also am very closely connected to a lot of social service agencies here in town. And I hear constantly from the folks that are going in there, that live here in Bells Falls, they're just not getting care. They can't drive to Springfield. They can't drive to Charlestown. They're not getting that
Good
primary
afternoon,
care.
Chair Foster,
So it's
members of the
feeding-
board.
Whoops.
The Vermont Hospital Association, the Vermont Association of Hospital and Health System, representing all our members.
Hey, Mike. Sorry about that, Marty.
That's okay.
Sorry, go ahead.
I kind of lost a little bit of my train of thought, but I just want to echo that people, this really has to be, I understand you have to bring healthcare costs under control, but it has to be about the people. That's it.
Totally agree.
Thank you. And thank you for what you do.
Yeah, no, thank you. I appreciate that comment. Any other public comment? Okay, great. Well, Ms. Westcott and Mr. Adcock, thank you very much for your testimony and for the budget submission and presentation. And if we have any follow-up, we'll get back to you. But thank you for your time today.
Thank you so much.
Thank you.
Great. Good to see you both. We'll take a 15-minute break and come back at 2:40. We'll come back at 2:50 for the Copley budget. Thanks.
Mr. Wooden. It's great to see you guys. When you do have an opportunity to speak, please let us know who's speaking so the court reporter can make note during the transcript.
Yep, no problem. Thanks.
Hey, Mr. Wooden, how are you?
I'm doing good. Thanks very much.
Okay, great. Good to see you and your team. We can go back on the record, Mr. Miller.
Okay, we're on.
All right. Mr. Wooden, I'll have our counsel swear you and each of your colleagues in, and then you can provide your presentation from there.
Hey, good afternoon, everybody. So I'm gonna administer the oath. Before I do so, just a note, after I administer, I'll ask that each of you just go through, state your name, and then affirm the oath. And as Kristen just mentioned, that way we have a record for the court reporter. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Joe Wooden, Administrator CEO, I affirm the oath.
Jeff Hebert, CFO, I affirm the oath.
Wayne Stockbridge, Chief Administration and HR Officer, I affirm the oath.
Jody Legacy, Director of Quality, I affirm the oath.
And Kathy DeMars, Vice Chair of the Copley Board, and I affirm the oath.
All right, witnesses are sworn in. I'll turn it to Copley to give its presentation.
Great, thanks. Can everybody see that?
Yes.
Nice. Technology's working. I'm so happy. Now I can relax. Up until that point, I always wonder if it's going to work. So the folks that are here today, we just swore them all in. Really appreciate your time. I've watched a few of these meetings. There's a lot going on. Hopefully we'll have a robust, helpful conversation here. Very thankful that Kathy DeMars is with us, board chair. Usually the board chair or vice chair shows up to the meeting. I think she's listed as chair, but she's actually vice chair. She used to be board chair. Kathy DeMars has been extraordinarily helpful in the organization over many, many years. And she's also administrative CEO of the VNA, Home Health and Hospice. So she brings a lot of excellent experience as a nurse. But I wanted to ask her if you wanted to make any comments, Kathy, or a few opening statements.
Yes, this is Kathy DeMars. I just wanted to open up by thanking you all on the Green Mountain Care Board for the work you do. I've sat on the hospital board for 11 years, and I know how difficult it is to make healthcare decisions. And we've made some tough decisions here, and I know you can't make everybody happy. So I really admire the work you do, and thank you for all of that and your commitment to healthcare, in our state. I also want to say that hospital boards right now are making really complex decisions with intense financial and regulatory pressures. So we're a volunteer board, and we really appreciate any support we can get from the Green Mountain Care Board and anybody on the state level for that matter, as we make these decisions moving forward as our healthcare changes and we need to make changes.
Yeah.
Thank you.
Thanks, Kathy. Okay, gonna walk through some slides. Here's sort of the table of contents. First, talk about the background and sort of overview of the hospital. This is our mission statement, and these are some of the pillars in the mission statement. It's a great place to work. I feel that way, and I think we notice that because people who apply for jobs, people who write letters of thanks and appreciation, we get a lot of those. Jody's going to probably talk about that in the end around quality. But it is, we're very happy to be here. I think people take their jobs very seriously, including the board members, some of them that are up here on the slide. So I wanted to just say that our history is wonderful. We like to go back and think about Mr. Copley, Alexander Hamilton Copley, love that name, who donated a lot of money. He wasn't a clinician, but he really helped the town of Morrisville tremendously with the People's Academy, golf course is named after him, the hospital he started, and it took many years, and it's wonderful history that the community came together. It took him a number of years to say, we really need a hospital back in 1932, which is pretty exciting. And I think the picture of the nurses, most of them came from way back when, Mary Fletcher. I think they came from Burlington. You can't really read their insignia, but we've been very proud and happy as the hospital has grown for going to come up on 100 years in just a while. I like to show this picture. I give this to new orienting employees. I do collect antique Vermont hospital postcards. Now, talk about being specific. It's a weird collection, but I think it's fascinating in the sense that, remember a long time ago, people stayed in the hospital so long that they wrote postcards to their family and friends. That is almost hard to believe. So this is the old Copley Memorial Hospital. It's a wood structure building. It's just like a 32nd of a mile down the street, pretty much almost next door. And that's now the Lamoille County Mental Health Services, the designated agency. So I do love that history, our relationship to the community. And again, I share this with folks. The one on the right is a food drive. And you gotta love the hospitals in America. Hospitals used to do linen drives where they'd collect sheets, pillowcases, blankets. They really needed the community, you know, washcloths, and they also did food drives. And this is just an example we found because we've got a lot of history. We got a book with every single patient. I think the first 25,000 patients handwritten and typed into a book, which is great. So this is just a little bit of fun. Overview of us: we're an independent nonprofit critical access hospital, one of 8. We're also a member of the collaborative. We're going to talk about that later. Our service area population, you know, I just want to pass this on to everybody as an educational moment. I apologize, but I do think it's important. The old-fashioned HSA, hospital service area, we say 30 to 50,000, but it really is an important denominator when you're doing the mathematical calculations of need, or how much of a urologist do you need, or what are you doing? The denominator is always, what is your HSA size? And so that I think we should always consider when we're looking at data and numbers to say, oh, you guys have more than enough X, Y, and Z. So that's why we put that range there, the HSA definition. CH hospital, emergency department visits, employees, members of the medical staff, our net operating revenue, and community volunteers. That number pretty much dried up during COVID. We all remember that. We actually had somebody, I'm going to keep her name out of it, in the OR. What was her name? She would still show up in the OR, get gowned up, and would still volunteer. Betty. Betty would show up, and we couldn't stop Betty. She's in her early 80s, and it was very helpful that Betty continued to volunteer. So we're glad to have the volunteers back, which is good. This is part of the overview for new employees. Overview of services. This is updated with some of the older names and crossouts. So if you see up top, OB is being tapered down. We're still going to have OB-GYNs, but they're not going to be doing OB, as you know about the birthing center closure. Urology, we just got notice of that a couple of weeks ago. So that service is going to go away. We don't employ that person. It's been an independent practitioner. That's what happens in small hospitals. We had a cataract surgeon. He's leaving, moving to the Montpelier area, so we no longer have that service. When that happens, we think about, should we try to employ somebody? Should we let the marketplace bring somebody to us? It's always a difficult conversation. It's not that we just go out and say, well, whatever it takes, get another cataract surgeon. So it is kind of interesting. The birthing center and OB we talked about. On the right-hand side, we did close the aquatic therapy pool program as well as sleep medicine, and we'll be showing you that. So this has been a year actually of quite a bit of changes this past year in the organization, and they're just difficult. Change is difficult. It's not easy, but it's understandable. Patients served, I think we're a little different than a lot of hospitals because only about 60% of the people from Lamoille constitute our workload. So we have a lot that come from Washington, Chittenden, Caledonia. So if you look at who we serve, again, back to what is your HSA? how many patients are you supposed to be serving? Well, this is kind of our history. This is what goes on. And here's patients by zip code for the FY24 data. We update this maybe once a year, but it's really interesting that people from Barrie or Burlington or Essex Junction or Montpelier, I love the bottom two arrows. Other towns in Vermont constitute 17, close to 18,000 total visits being inpatient or outpatient, which is really a big deal. That's a lot. That's the second largest town outside of Morrisville, which is listed up there. They're alpha sorted. So Morrisville's at 23, and our second biggest town that we serve is called Other Town, Vermont, which is kind of funny. And we have out-of-state folks. So, 56 patients that constitute about 2281 outpatient procedures. Another overview, you guys all know this, but it's great to be reminded. This is the way we look and sort ourselves. Academic Medical Center, which is a tertiary PPS. You've got the 8 critical access hospitals at the bottom. We're one of 8. And then the standard PPS, which goes back to 1983, the change in reimbursement that happened. I'm only bringing this up because I think the methodology that we use, which the Green Mountain Care Board has been using by looking at folks by size, it's a great movement in the right direction to say that, because we're all different and unique. But also you could look at hospitals by whether or not they're part of the Dartmouth system or the UVM system, which would make sense. I know AHS lately has had some ideas of how to sort working through RHRC. You could also say north and south makes a little bit difference, just because the southern part of the state is much closer to Massachusetts, Rhode Island, and New York. You could even do east-west, like I said, Dartmouth or UVM. There's a lot of ways to look at how we deliver care and make sense. Here's our size based upon others. It's a very humbling slide. Yes, we are only 3% of the hospital budget spend. And this slide shows that back in 2022, I didn't update this, but I want to show you the update. We were running as a state about $3 billion, which is a big number. When you say the B word, billion, that's like, wow, 3 billion. But when Jeff updated this, Jeff has all the data. I just get to present it. He does a great job. So we went to 3.636 billion in 2 years. I bring this up because I talk about these things with a lot of people and venues. The hospitals alone spent $620 million more in 2 years. And I know we always look at the data to get a sense as to how much in crisis are we, what can't we afford. This one, when I came across it, I was shocked. Given our population size, to say in 2 years, we are now spending $620 million more. It does make us all pause. And I think all the work that you guys are doing and we're all trying to do around healthcare reform, transformation is necessary. I hope it continues, and we might have to continue to be more assertive. Strategic plan, this is our plan. We're going to update it this year. We spent a lot of time doing it. It's important. Can't imagine doing it more than 3-4 years. Sometimes it changes dramatically in 1 year. Our main categories, and I can't imagine they will change ever. I didn't come up with these. It's just a group process, which is finances. And we did put it first with a lot of lament from people to say, oh my gosh, I can't believe you have finances first. Well, the sustainability of Copley and the finances need to be first because it is front and center a concern. Quality being second. And I'm hopeful maybe this go around with the strategic plan, at least maybe the next time we put quality first and say, finances are controlled. They're always in our peripheral, but they're not front and center sort of being a huge concern or raging. So those two are always going to be first and second. Workforce culture, of course, for small critical access hospitals, that's part of what we do. We're not a teaching hospital. We don't operate in a bunch of states. So these are all sort of simple: workforce culture and keeping care local. But not all care. Of course, we made a decision, but doing our best job we can, because people would rather not travel when in fact, if it is relatively routine, simple, and plus it alleviates, the 2 medical centers And we learned a lot about that through COVID. So as part of the finance chart, I'm not happy with this chart, but it's helpful for us to look at our operating gain and loss at the end of the year. And so we've had a lot of years of losing money. They do add up. It is hard to cumulatively get out of those years because each year that you get behind, it almost that you not only have to maybe pay that back, but there's sort of interest, and you know that time is not in our favor. As time goes by, everything's getting more expensive, whether it's construction, labor, et cetera. So this is what we struggle with. I know Jeff and I will be talking with this, but that's kind of why finances are at the top of the list. So service lines, I want to talk a little bit about service lines. In this one, I put growth and shift up there because that was part of the Oliver Wyman report. And it's easy to complain about that, but the Oliver Wyman study, I think, was always saying to each community and each organization, in some areas you should see if you could grow and enhance and maybe become a center of excellence. In some you need to probably shift, partner, and question, can we afford to do that? So here's one of them. This is from June 2024. It seems like it was more than just a year ago. It seems like it was a lot more than a year ago, but this is some of the reports, and this is where Copley is noted in some of those yellow charts, you know, grow or shift birthing to other organizations. I think it's a nice way of saying it, but when you dig into the data and ask people and read between the lines, I think directionally Oliver Wyman has helped us look at these things. Second one is become a regional referral center for orthopedics, something that I think we've done and will continue to do. So that one is sort of grow that, make sure you continue with that. And the right-hand side is execute on shared services with other hospitals. I think we're doing that very well. There's a group of us, and I'm going to talk about that a little bit later. And, you know, even strongly consider formation of a regional specialty medical group with other hospitals. We're also considering that. That's a lot more complicated, but I like that it's out there, and it's a suggestion that how can you folks work closer together, almost like a network, the independent hospitals. A couple of other slides with the COE. We love our initials in healthcare. Sometimes it drives me even crazy. Center of Excellence. And so down on the right with Copley, it's sort of a suggestion about orthopedics. Continue that, or make sure that maybe we all recognize that, which I think is great. Above that's neurology. We actually have a community neurology service that does well. So it's not that we would end that. It's hard to even find a neurologist. I love all these ideas, but you have to sort of look at the circumstances, people that you have. And we also have a very active and renovated infusion therapy chemo unit. So just mentioning those. Service line reductions this past year. Again, some of these have been intentional. Some of them we just experienced. The sleep medicine services, we did seriously look at that. What are the volumes? What are the expenses? And it comes down to recruitment of staff, retention. We need certified overnight sleep technicians, medical director. So we were using travelers and locums and found people that could help us in terms of the MD side. We even had a traveler, I think, on the sleep technicians. It just became not helpful. I know there's some need out there, but we really couldn't continue pulling that off. The aquatherapy program, we again had low numbers, volumes, expenses with that. I think the pool liner alone replacement is $40,000. We got that in the mid 2000s, and at that time there was not outpatient orthopedic surgery as it is now. Pretty much like 90 to 95% of all of our orthopedic work is outpatient, so that the pool therapy program, either prehab or post, is really not used, and so we made a decision to close that. Cataract surgery, we had Dr. Doyle working with us. He was great. Everybody loved him, but I think he's moving towards the Montpelier area, so we're not doing cataracts, and we're not aggressively looking to replace that. We just sort of wait and see. And if somebody moved into our area from wherever and said, "Oh, I now live in Stowe or Morrisville," then we would be like, great, let's talk to you. And then the birthing center, which everybody probably knows about, was a really huge decision. And I'm going to comment on some of that going forward. This was the chart that finally got printed in the newspaper that people saw. And I think a lot of people, it was eye-opening to see the percentage of drops that we had that were significant going back to 2006. We do have some data going back that gets a little bit squishy and a little bit gray. But the issue of whether or not we should continue with the birthing center, prompted by Oliver Wyman, but never in our strategic plan. We never actually really thought about this. And when it was brought up, we said, yeah, I guess we really should look at this. And we found out, I know Kathy's been in the community a long time, but she hasn't been on the board for 25 years. But we found board members and others who would say, oh yeah, over the years, you guys have looked at this a number of times. I don't know, I think the count was maybe 3 or 4 times. We had people say, yeah, we looked at that back in the 2000s. We looked at it 2010. We looked at it again. So this was helpful to see at least that trend. The other thing that ended up in the newspaper, which was helpful, sometimes the newspaper can be looking for helpful. Sometimes they're just looking for stories. And this is just sort of what's the birthing center number of births, and that number fluctuates. Sometimes it's 170, 180. It's been going down lately. But so that's just a perspective about all the other work that we do, and I thought that was helpful. Now, this has been a very difficult discussion. I will tell you that. This is probably one of the most difficult things I've gone through, having worked at 6 hospitals, been a CEO at 4 of them. But I'm going to let Jeff talk about the quick financial data, and then we'll talk a little bit more about the decision making. So this is just one chart.
Just one chart. So the data up on the screen, to actually do this analysis of our birthing, we utilized our 2023 cost report data. We actually worked with Helms and Company to validate that data and all the assumptions that went along with that data. We also had some opportunities to reach out to other organizations that went through the same process. And, when we actually saw how they did it, it was very similar to the approach that we utilized. So going up onto the columns, I'm going to try to explain the hospital department. Those actually represent the hospital's birthing unit, our L&D department, and our nursery. The next column over is our outpatient clinic. This is on the area where our providers and APPs are expensed and the revenues recognized. And then the next column over is our OB ancillary. We actually needed to understand which departments actually benefited from our births. And those departments would be like our OR, our radiology, our lab, and et cetera. Moving over to the next area, this is the partnership option working with Helms and Associate. And what this option was is we would work with other hospitals, and Copley would do the ante and postpartum care, and Copley would also keep its GYN services. And so moving down the total impact, that last column, our net revenue with this change is coming in at 1.1 million going down. And our total margin in this study was removing 2.9 million in margin. The data that is in our budget is actually 11 months, whereas this data is 12 months. And the other thing is we also, for 2026 budget, did put in closing costs, which include the possibility of using additional locums, travelers, working with our community relations departments, et cetera.
So we actually studied and called a number of hospitals to find out who went through this, what did it look like when we first addressed this with the board. It immediately became a very emotional and difficult issue, and staff, others, I know our nurses union got involved, and I think, coordinated flyers. And this was a really difficult process. You know, on the bottom right, it's got 2,732 signatures. The problem became save the birthing center. Don't even have the discussion. Take away the decision-making process by ginning people up to say, you've got to prevent the closure and save the birthing center. It made it really difficult for all of us, the board. We did hire the outside consultant that Jeff was referencing to really make sure that, you know, the Oliver Wyman report was prompting. They had some suggested minimum births for a hospital. If you go below that, sort of questioning whether or not you should do that. RHRC also had some minimum births. Healthcare does not like volume requirements, but this was really, I've never seen anything like this, and it felt really disrespectful to the board who ultimately makes the decision. You know, we make a recommendation, but the board really, we had somebody quit the board.
Right.
I don't know.
It was incredibly stressful for the board, and we each personally received probably over 200 letters to our homes from various people, and some of them were not very kind.
Yeah.
So it was very stressful for the board through the whole process.
It became really discouraging. And again, we lost one board member. Others were just like, you know, I really appreciate the hospital. I love it, but this is overwhelming. And then we had the rallies, you know, save the birthing center, let's not close it. And we're in the middle of the process of understanding this. Again, knowing that this has been done 3 or 4 times in the past. And it came down to us saying, well, despite all of the roadside signs, I had people tell me they're up in Newport, they're down when you come across from Lake George, they're in Chittenden County. It was more than anything I've ever seen, and it made it really hard. But at the end of the day, it really came down to a discussion is, can we afford this? And do we have enough volume to constitute a direction towards quality? So I know that's hard to say, and people really would fight over those issues. As a perspective, and we did a lot of research, you know, over New York Times article from December 2024, not that long ago, over 500 hospitals have closed in a study from 2010 to 2022. So that's give or take 12 years. 500 hospitals have closed the birthing centers. So 2022. 2023, we had an additional 20, well, the number got up to about 570 to 600. It's amazing how the data is not always kept. In 24, there was another 37, and in 23, there was a similar number around 32. But that's a lot. That's, you know, give or take 600 hospitals closing the birthing centers. And the reason why they would do this is because of mainly financial distress. That was the primary driver. In any healthcare system, sort of known, I've discerned this, but we see it, that if you're in distress, what services can you really not afford because of not even getting labor? And the three services that are most difficult are inpatient psychiatry, which we saw UVM close at CVH, understandably. Really hard to get inpatient psychiatric. Even worse if it's a lockdown unit versus inpatient regular unit. The other is nursing homes. And nursing homes, we just had Genesis make that announcement 2 weeks ago, 3 weeks ago, that Genesis was closing up, went bankrupt, whole bunch of nursing homes. We know the stress of running a nursing home. Very difficult to get staff, a lot of needs, and yet all of us cry for this situation, much like the births, because it's our elderly, it's our frail elderly. And the third of the three is birthing centers. So just wanted to share that and give it that perspective. Now, the amount of communications, you know, there was a lot, you know, close to 400. Most people just being against even deciding it. Television, articles, opinions, newsletters. We continue to get stuff on Reddit. I mean, people were really very upset with us even thinking about it. And some of their comments were very hurtful. And that's really hard for all of us. We are trying to do the best job we can. on a number of fronts, healthcare is really complicated, but I do believe the outside perspective of somebody saying, where can you find opportunity for improvement, coordinating together, getting rid of waste, how can you become more efficient? We are trying to squeeze everything possible. And, but some of the comments were just really very biting. And here's a few more comments. Some of the stuff is pretty wild, like Copley's projected to make 10 million next year. If you remember the first chart, Jeff will show, we haven't made 10 million if you add up 10 years of operating margin. I love the third bullet point, lucrative bonuses for board members. That's been mentioned a couple times. Well, the board, you ought to look at what they're getting paid. The board members, they give more than any other volunteer. And we've got, hundreds, 200 volunteers. Board members give their time tremendously. Kathy, appreciate you being here. They give their heart and soul and their emotion, and they love this community. And some of them have been here for generations. And so it's when you're picking on the board members and saying they don't really care, again, it's kind of hard. So I just wanted to share that with you. My concern with all of this is, are we strong enough to actually do these things? Because the road ahead is not going to look easier and brighter when it comes to all of us being asked to think differently, less egos, share services, try to help each other out. We study this, and we did come to the conclusion that we probably should do this, we need to do this, and we need to make sure that we're saving the greater hospital. We did talk to our partners, they've been very helpful. Sort of the UVM network has been very helpful. Sean Tester at Northeastern Vermont, Tom Frank, as well as Peter Wright up in sort of the North Country. They've been all very helpful with Sunny Eapen, and some of them are looking at bringing staff to help with the prenatal care and postnatal care. And, you could say, well, why wouldn't somebody else close? We had the lowest volumes. And yet I think we still need to coordinate on not only births, but other services. And we're going to have to continue to go down this road. But everybody's been supportive. I know members of the Hospital Association, everybody has said, wow, Joe, we really know that you're going through a tough time. Good job. We're with you. But it's not been easy. So thanks for listening on that. That was therapeutic for me. I needed it. Service line support as opposed to just cutting back. We've spent a lot of time this past year. Kathy has spent a lot of time as one in this room working with Memorial Health Partners, our FQHC, supporting them in 24 and in 25. We provided an emergency grant of about $150,000. We entered into a memorandum of understanding back in December of last year to think about how we could maybe become much more integrated. These are tough discussions too. These are not easy. We'd love to help out and be more of a team. And I think sometimes when we all start running out of money, all of a sudden the issues that you don't want to talk about, we need to talk about. So we have tried to help them. They transferred some of their lab work to us from New Jersey. We really appreciated that. That's been helpful. They had to close their Stowe clinic. It was really unfortunate, understandable though, and their diagnostic there, some of that has gone to us. And we purchased a very large MOB as opposed to an MOU, medical office building. Love the acronyms. We purchased that, which is across from the hospital, with some cash up front to help them out. That was part of an effort where they were working with AHS and a number of others to get help and relief because of changes in leadership and just having a hard time being primary care. The other big service line support across all surgical services is for us to add this fourth OR, which is a direct response to increased demand for services. We've got a growing patient need. It improves our finances, keeps care local. And our waiting list on surgery is very significant. Now, the funny thing about this is back in 2016, I think the CON probably started in 2014. It took a long time to finally have Copley rebuild their surgery center. But Copley did have, they had 2 procedure rooms and they had 3 ORs, and Copley through that process wanted to add a procedure room and an OR. And in the end of the process, and I'm not blaming the Green Mountain Care Board or the Public Oversight Committee, it's just a difficult process. They didn't get a procedure room and they didn't even get an OR. They just got to replace their existing. So we've always been short volume-wise, both a procedure room and OR. So this is actually an OR that we had a demand for going way back. So,
And we should say that OR is not just for orthopedics.
oh,
It is
no,
to
no, no.
increase our women's care who are surgically, the GYN services have increased and we need that time in the OR. So.
Right. And we have a lot of general surgery
Correct.
cases. Sometimes we use it for pain. We used it for urology. There's a lot of other folks that use it. It's not entirely. Thank you for saying that, Kathy. I know sometimes people think that, like we only care about orthopedics. That is not
true.
That's not true. Yeah, we care about as much as we can in terms of what we can. Other areas, oncology and infusion, that was renovated, and we saw a lot of this, and we're still seeing this in our FY25 performance. We moved to a larger renovated space, which was really important. That service is well loved. That service engenders a lot of commitment and appreciation from all the patients. The staff do a fantastic job. The laboratory services we talked about, that was a switch from Quest, a for-profit out-of-state lab company. Just saying it like that. I wish
Hi,
none of the
Colleen
work would go.
Sotradich here. How are you?
I'm doing
Good.
okay.
Is Summer Birch around? Does she have a moment?
Somebody who doesn't.
Oh, maybe somebody needs mute on.
Yeah, I think we got it.
Okay, thanks. So laboratory services, again, I'm a little concerned that any lab volume goes out of state to a for-profit. Radiology mammography, we've got a very significant upgraded mammogram machine that does contrast enhanced mammography for not screening, for diagnostic, and in fact, will replace potentially the need for us getting a breast coil for the MRI. It's really new technology. Dartmouth doesn't even have this yet, and they're helping us put this into practice. So it's much better and easier, and we have access. So wanted to just point that out. And then general surgery, we lost a surgeon that did colonoscopies. He was here for like 30 years. Dr. Silverstein, Joel Silverstein, he came down with some significant medical issues, but we got a replacement from Dr. Lou May. Again, as this story can sometimes happen, he moved into the area and somebody said, you ought to talk to the hospital. He's very skilled. He's been doing colonoscopies, upper and lowers his whole life. He came from a practice with 8 to 9 specific GI folks, so we're really happy about that. So we are open for those opportunities. I want to talk about the collaborative next. We call it the collaborative as opposed to spelling it out. It is the